all here. Council members are all here. So I'd like to welcome everybody to this meeting of the Early Learning Council on February 23rd, 2002. And Remy, will you please call the roll?
Yes. Angie Blackwell?
I'm present.
Katie Brooks?
I'm here.
Peter Buckley?
Here.
Ann Kubich?
Here.
George Mendoza?
Here.
Dr. Peg Miller?
Here.
Kali Thornlad?
Here.
And then we have Sue Miller, chair. And I know that Sue's here. And then let's see. I guess we have Kate Wilcox here for Pat Allen, the director of the Oregon Health Authority. Colt Gill, the director of the Oregon Department of Education, is excused today, and he has provided updates. Margaret Salazar, the director of Oregon Housing and Community Services, I believe she is excused as well today. She has moved on to a federal position. And then Liesl Wendt, the deputy director of the Oregon Department of Human Services, is also excused today. And then finally, we have Alyssa Chatterjee, the early learning systems director of the Oregon Early Learning Division.
Here.
Excellent. And it looks like we definitely have a quorum. Sue, if you want to take it back.
Okay, thanks, Remy. And thank you all for being with us today. As you know from the agenda, we are very excited to welcome our Oregon Health Authority partners this morning for joining us and sort of being the kickoff agency for this approach to council meetings, where the council has talked for about a year about trying to have a deep dive with each of our partner agencies so that we have a chance to really learn from and explore what the agency's early learning agendas really are and how you're working with prenatal to 5-year-olds and their families. So, and I have to say to the OHA staff that your boss, Pat, agreed to this early January before his world changed. So I just want you to know we didn't intend to just sort of drop this in your laps, but life happens. So we appreciate each of you being here today. And let's start then with Steph Jarman, and she's going to talk about the Medicaid waiver, which is incredibly exciting as well for all families, but certainly for families with young children. So Steph, welcome.
Thank you, Sue. And Remy, are you able to do slides? You're already on it. So thank you for having us here today. My name is Steph Jerem. I'm the director of the Office of Health Policy within OHA's Health Policy and Analytics Division. And if you go to the next slide, you'll see that OHA is here today to talk about 3 different aspects of our work that relates to early childhood and children and families. So first, I'm going to give an update on the waiver, and then we have Sarah Kleinschmidt here who will be speaking about the social emotional metric update that's been done in collaboration with some partners. That is really exciting work. And then home visiting and Family Connects Oregon implementation update that Kate and her partners will be sharing about. So next slide, I'm going to speak specifically to the waiver. And if you go to the next one, I wanted to set the stage overall in terms of our strategic commitment to kids in our agency. So when we think about OHA's efforts overall around our strategic goal, what's driving us in our work, it's to eliminate health inequities by 2030, which is a tall ask, but is really driving the work that we're doing. When you consider it from the perspective of this council, especially improving outcomes for kids is fundamental for this work. To be able to reach our goal, we really cannot get away with addressing any inequities that we face at the child level. And so the types of things that how we see this play out in our work, really strengthening and supporting the foundational public health programs that impact maternal and child health. That's some of what Kate will be talking about. Incentivizing better care for kids in Medicaid, huge population of kids that we really have an opportunity to ensure access to care, equitable access to care in our Cco metrics. So that's some of what Sarah will speak about in a bit. And then finding opportunities to increase culturally specific access to care as well. So that is throughout our agency, one of the areas that we're working on. If you go to the next slide, I'm going to speak about our waiver collectively and really what this means. I think some of you are probably very familiar and have seen parts of this presentation already. For those who haven't and who may not be familiar with our overall health system, we have lots of different kinds of waivers in our state. Anyone who's on the Oregon Health Plan based on income is really who we talk about when we're talking about a waiver population. So OHA provides healthcare coverage to folks on the Oregon Health Plan. The federal government is a partner in all this work. They fund a lot of it, and they set their own standards and expectations around eligibility. What are the required benefits for a population? States can then waive some of those federal rules for greater flexibility and to kind of test out or demonstrate new ways of providing care. So that's what a waiver is. That's what we are talking about. We have a lot in our state that is not just this big 1115 one, but the one that we're here to talk about today is our most significant one, impacting the most number of people on the Oregon Health Plan. And so every 5 years, we have to go through this process to kind of re-up the agreement with the federal government, and then also have an opportunity to propose new changes or continue our existing ones. Federal government really gets to decide here. They get to accept or reject the proposals, but I am really excited about what we are proposing. So if you go to the next slide, I spoke to this a little bit, but we're really focusing on this 1115 demonstration waiver. It's the broadest one. And these are the types of things that we can change in a waiver for people on OHP. And I should point out, the number of people in OHP is about 1 in 4. It's actually a little bit higher than that in our state right now. And somewhere between a third to a half of kids under 5 are on Medicaid in our state. So really impacts a huge portion of our kids. If you go to the next slide, I just wanted to call out our health equity definition again. This is driving the work of our waiver, driving the work of OHA. So if you haven't seen this, there was a lot of work done with our health equity committee to develop this, and it's now in rule and is really helping a lot of our understanding of our work moving forward. 2 strong components driving some of the work in our waiver is around how to address and achieve health equity, requiring equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So these are 2 components that we are trying to weave throughout our waiver proposals to change how we think about Medicaid and how it impacts families and kids in our state. And you'll see that on the next slide by understanding our big policy expectations and the different goals that are driving this waiver. So first is to maximize coverage through the Oregon Health Plan. So say we want people to be able to be on for as long as they can. We want people to have the most consistent coverage. Second is to improve outcomes by streamlining transitions. People go through a lot of transitions that are destabilizing. Third is to encourage smart and flexible spending focused on health equity. And then fourth are focused health equity investments. Okay, so next slide, I'm going to go through these briefly and I'll get briefer as I go. The first one is really our biggest one, most specific and impactful, targeted to kids 0 to 5 would be to provide continuous OHP enrollment for children until their 6th birthday. So at any point in time, if a child becomes eligible for Medicaid and they are under age 6, they would just remain on until their 6th birthday. And this is really fundamentally, it's a completely unprecedented ask. I think we're getting relatively positive feedback so far from CMS in terms of our initial conversations. We'll see whether or not they end up going for it. But really, huge opportunity in this, creates a lot of continuity for kids, takes a burden off of parents. Otherwise, they'd have to be re-enrolling every single year, even if they remain eligible. So, big ask. The next slide, the other 2 strategies are in establishing 2-year continuous eligibility for everybody else on Medicaid. This is going to help us reduce the churning in and out of Medicaid, so people don't know when they're not covered. A lot of times it comes down to like not returning paperwork, which we know is really not a good reason for people to not be getting access to healthcare. And then working on a direct enrollment pathway to OHP for those who apply for SNAP. So that's another one to try to just streamline opportunities for children and families. So as I said,
Steph, can I interrupt you 1 sec?
Oh, please.
Do you want to take questions from council members as you go, or would you rather make your presentation and then take questions?
I am happy to take questions as I go, make it more of a conversation.
Okay.
So please feel free if anybody has questions at any point in time.
Okay, I guess I would just throw one in on the last slide.
Mm-hmm.
Is this like the first in the country where people are asking for kids not to get kicked off?
Yes, we are the first to formally put that forward. I know Washington has also been working on something similar, and I don't know where they're at in their waiver process. There's a lot of strategy and politics around waivers and federal administrations as well, in terms of when one state asks for something and sees a real opportunity, there may be a lot of other states that really jump on that and create some continuity and equity across multiple states in terms of what's available. So I will definitely say Washington, I think, had this idea first, but our waiver came up first. So we're able to kind of partner and collectively work with other states to move forward on exciting ideas.
Wow. Okay, thanks. That's incredibly exciting.
Yeah. Okay. So the next, the rest of the waiver strategies, I do want to make a point, are not targeted specifically at kids 0 to 5. I think there are a lot of indirect ways that children and family are affected by these policies, and there's potential for kids and families to be directly impacted, but we leave a lot of that flexibility up to the individual Ccos to make some of these decisions in communities. So I'll go a little bit quicker through some of these, but please stop me if you have questions or you have other comments. So the vision in this concept is to say that people should have equitable access to services and supports, especially through times of transition. And so that could be transition across systems, in and out of systems, or across major life events. We know that those are destabilizing, and it's times when people might, lose access to medication or lose a provider that's been helping them through a time period that is really difficult. And we want to make sure that that doesn't happen. So we're focusing on transitions.
That's quite a visual you used for that.
Yeah, very clever. So the proposed waiver strategies in this bucket, there are 5. The first is to waive eligibility so that people can have OHP coverage in a longer time period. So when they're in prison, jail, local corrections, juvenile corrections, Oregon State Hospital, or psychiatric residential treatment. So extending the amount of time, that's likely going to look like 90 days before release, and then also an extended time until while they're in pre-adjudication. Then the next one would be to extend coverage up to age 26 for youth with special healthcare needs. We heard a lot about the challenges of this population being able to transition effectively from the pediatric system to the adult system and the difficulties there. The next one would be adding and expanding the type of services that can be provided. So that when we think especially about children and families, I think about these wraparound supports that could be helping. So when an OHP member, and let's try to envision this as a parent, has any of these events happening, like becoming homeless or getting out of jail or prison, or a child is entering or leaving foster care, we are hoping to provide additional social supports for things like housing supports and services, transportation in and out of jobs, transportation to prior schools, those types of things, food assistance, filling a fridge so that when somebody is just released, they don't have to worry about trying to figure out how to go to the grocery store and navigate things that they haven't done before, as well as employment support. So those are really the 4 categories. And there are additional ones within some of them, like within housing, there are additional wireless technology, broadband support, things like that, if it's for employment or for schooling. There can be additional utility support, first and last month's rent, things like that. And I see, Angie, you have a question.
I do, thank you, Steph. So on the previous slide, it indicated that you're asking for youth with special health needs to stay on until age 26.
Yes.
I'm wondering about those youth that age out of foster care. This slide mentions supports for those entering or leaving foster care, but is there an age cutoff? How long are they eligible to stay in?
So right now, kids with foster care, I can't remember if it's at 19 or 21. The goal with this would be to provide supports in advance of that. If they're aging out, that we would be supporting that age out as well. It does not support extended coverage to an older age, but I would need to go back and check because I think there are some situations for kids aging out where we keep them on until 26 because we match the experience in the private sector ACA coverage up to age 26, and we're basically they're a charge of the state at that point, so same responsibility. But we can definitely get back to you.
Thank you.
Yeah.
So this I don't see another hand. So Steph, with this slide, the social supports, I'm just wondering how you envision that happening. Are you asking for more money from the feds in order to cover some of these supports, or?
Yes.
And yeah.
Yes, so we are asking for an additional amount of money that the feds will supply. There are 2 different ways that we can ask for those funds technically. So we kind of have a plan A and a plan B. So some of that would be for that. I think fundamentally, at OHA, we also recognize that a lot of these investments pay off in the long run in terms of lower costs and stabilizing and improving health and wellness for children, families, others. And so this is something we want to be incentivizing Ccos to be paying for. And so there are other ways in which we can encourage that. That's maybe more of like our plan C. That are ways in which we can ask for payment. I'll get to this a little bit later, but there's also a way in which the Cco rates can benefit. And this is, I don't know, maybe too technical, but for those of you who may be tracking some of this, we pay the Ccos a rate per member per month. And they really have to be creative with how they use that funding. And so we're trying to change a little bit about how some of these investments count in their rate development to incentivize them to further use these types of services for members. And that's another CMS ask. So a little, we're kind of setting up how we think it could happen, and we'll get feedback about whether or not CMS agrees.
Got it. Okay, thanks.
Yeah. Okay. So next slide, that gets into this a little bit. So the other pieces of this transitions bucket of work would be waiver of covered services. So really expanding who can provide types of care to our members outside of the medical model. So again, a lot of strength in our traditional health workers across the state, our peer support specialists being able to provide supports and are currently limited in some ways by existing rules from the federal government. So we want to waive that. And then that piece that you're asking about, Sue, the additional federal funding. So actually paying for services to support those transitions. And then we also have an aspect here around child welfare and psychiatric residential treatment, and some creative ways that child welfare has put forward in terms of ensuring access to services. So a lot of additional layers there in terms of an overall shortage of like a workforce shortage and things like that, that can create some challenges, but we're leaving it in the waiver to see where there's opportunity. And so overall, what that means for our members is really just thinking about how to stabilize care for OHP members to keep coverage in more services and more situations. And so again, this really highlighted the major transitions we talked about: state hospital, psychiatric residential treatment, jail, juvenile corrections, prison, use of special healthcare needs. There are a couple other ones that I didn't mention. One is people who experience extreme weather events. So thinking about some of the fires and the evacuations and the challenges that children, families, adults face in returning home or receiving supports while they were away. Difficulties. I mean, we heard of a whole situation where a woman was in labor having to go to another hospital outside of her Cco region, and the difficulties that created, not having a place to return to, just a lot of challenges. So being able to support that in a more effective way. And then the last one would be for elderly adults who have both Medicaid and Medicare health insurance. So basically the transition becoming a dually eligible person is another one that can be challenging to navigate. Okay, and so the next ones, these are, I can point you to a lot more information about them, but they are going to be more technical around funding. So the next slide, this is our vision of CCOs, and CCO payment would be to say that we want to pay CCOs in a predictable but flexible way, and then really push on this incentive to think about CCOs going even further in supporting medical and social needs and investing in that upstream preventive care, community health, knowing where that's going to lead as a state. So that's our vision. And so why do we want to do that? That really will help us to encourage CCOs to spend money in ways that truly keep people healthy at a community level. The way that we're going to do this is through tweaks to our payment rates, as I mentioned. So it'll be a longer runway is what we're trying to do, a longer way of looking back at what the investments have been to predict a longer future for them as well. So it's a little bit more predictable. The other way that we want to incentivize equitable care, and this does come back to some of the work that I know this council has been interested in, is around our metrics program. So Cco metrics have an incentive program. I think everybody's familiar with that. Talk more about that in a bit. So if you go to the next slide, there's a desire to really think about this metrics program and say, how can this metrics program, which is responsible for so much additional funding in the state, really use equity as an organizing principle underneath the work? Let's rethink this. Let's build on what we have been doing. So the way that this would happen on the next slide would be to change how it is described in the waiver, splitting it into two parts: an upstream set of metrics and a downstream set of metrics. So one part of the incentive program will consist of metrics that address health equity at the top, these upstream ones. They are going to focus upstream to correct historical and contemporary injustices, An example of the type of metric that this would include would be the meaningful language access to culturally responsive care. Downstream metrics would be the other part of the incentive program. This would continue to line up with our standard health metrics used by Medicaid organizations across the country. These are already required by the federal agency that oversees us. So they would be focusing more on the traditional medical care, such as diabetes screening or controlling high blood pressure. So kind of considering two aspects of this work. So if you go to the next slide, the incentivized equitable care, those upstream metrics, the hope here would be to retain all the ones that we've been working on and building around children and youth, social determinants of health and care and system and care coordination. One example is the Cco system level social emotional health metric, which we'll be talking about in a little bit, as well as the social determinants of health measure, which will first be incentivized in 2023. So really wanting to retain a lot of the work that Oregon has been doing in thinking upstream and focusing on kids with that work. We don't want to lose any of that. So what would that mean for Medicaid members? We want to see that OHP members and communities have a greater voice in the quality incentive program, and that the hope would be that the results of the changes to this program, we will be measuring and rewarding improvements that actually matter the most to the communities that we serve and those that have the greatest chance of improving health outcomes.
So Steph?
Yeah.
Are the upstream incentives, do they just not exist right now? Is it all the downstream? So that's kind of the change?
They do exist. I think the goal would be to more intentionally call out that this is a purpose of the work. I think it has been a reframing. Every time we've had one of these newer incentives, there's a lot of work to kind of say, is this really the role? Should we be doing these new types of measures? This is different than how we've done it in the past. And so by describing the program as intentionally having a purpose around this work, we hope that that will lead to greater interest and greater understanding that this is what we are supposed to be doing with the metrics program.
Got it. Okay.
The other component of that is that they will also be set for the life of the waiver versus having decisions every single year for the committee to be making.
Thanks.
Yeah. And we do have Sarah Kleinschmidt here, who is our expert in this area. So if we do have more questions on the metrics program, she would be happy to speak to it. Yes, Peter.
Steph, this is great. So if I'm understanding this correctly, and I'll use an example from Southern Oregon, we have Rogue Retreat, which is doing wonderful work, getting people off the streets into safe campgrounds, then into supported housing. So our community could have a greater voice in saying, we think that should be an even greater incentive for the CCOs to invest in that program because it's getting results.
That's a creative idea. I would look to Sarah. I don't know if you want to jump in on any of this.
Sure, I can jump in.
Yeah.
Give me a second to turn on my camera. I think part of it is setting up. Steph is not getting into the minutia of the change, but one of the things that we're doing is changing the committee structure in terms of how decisions are made about the program to have greater community voice in the things that are incentivized and measures. So like what you're talking about, something like that could be considered by this other committee. So it's really a lot of change around the governance structure, and that then I think lends itself to, where as an incentive program, where we go, where do we want to drive? You have incentive measures because they drive behavior change. So what's the behavior that you want to change? What's the things that you want to incentivize? And right now that's not community led. And what we want to get with this change is that direction is community led. And that can be at a high level. And then it can come down to the individual measures that we're talking about as well.
Great. Thank you.
Sue, could I ask a couple of questions? This is Anne.
Yeah, absolutely. Go right ahead.
Well, this is just so great and so exciting, and I can't wait to hear what's coming next. But on the upstream inequities, one of the things that is on our mind all of the time is, so you gave some examples about race and so on, but we also are concerned about geographic inequities and the inability for rural folks to get access to, especially rural folks, to a lot of the healthcare they need. Is that part of how you're thinking about some of the upstream inequities?
It's actually yes, and it's the upstream inequities. And the other piece that I want to highlight is those downstream measures that Steph was talking about. So the things that happen in a clinic, there are inequities there as well. And one of the ways we want to move forward is to be able to stratify and look at those measures. So are there differences for folks who have diabetes by race and ethnicity and how we're treating that and managing it, or by rural versus urban? And so yes,
Great.
Those are all of the things that we want to get into and be able to look at.
Good. I appreciate that, because just knowing how you're going to include the rural in this is something that is really going to be interesting to us. And I appreciate that you're paying attention to that geography too. On the question of the incentives around social, emotional, and other kinds of things, we've been doing some work about that in Douglas County. And one of the things that I feel like I'm learning, or as I watch it from a distance, is getting communities ready to actually be able to do these kinds of incentive metrics, and getting all of the actors in the community ready to know what they are and to actually use them and understand them is part of it. It's, I guess we can say that these are the incentives, but then how do you build the capacity to actually use them in a meaningful way? How are you thinking about that?
It is an ongoing process. I think the way I think about it in my head is what you're talking about, is that, so there's a measure, we have the measure, and then how do you implement it, right? Like, how do you get everybody together to do the thing? And so some of that work we have through what I'll talk about a little later is our transformation center, where we provide technical assistance. And I do think we have more work to do as an agency and with our partners in thinking through more and better that implementation piece. Particularly as we're moving upstream and we're looking cross-sector, that becomes even more important.
Right.
So there was actually just a meeting last week we had internally about all of this and thinking about all of our quality improvement efforts. So I don't have the great magic answer of what we're doing there, but I think the fact that it's being raised and recognized is really important, and it's something that we need to do some work on and do better on.
And I appreciate that you're talking about sort of the governance model of this, because it really will require so many different sectors to be engaged in the discussion at the community level, how to do this. And so it is actually, a multi-sectoral collaboration that becomes really complicated, but needs to happen at the community level. And there need to be attention to the governance and process issues is really important. So that's great that you're thinking about that.
Miller, I have a,
Go ahead.
I had a couple questions, but I can.
No, go ahead, Colleen.
Okay. Well, I guess I have questions dealing with the community engagement piece. Are you going to talk more about that stuff?
Yeah.
Or is it, okay, so maybe I'll just hold and wait and see if you answer them before I ask. So Peg, you're good.
I just had questions about, I fully support the upstream, the kind of the separation of the upstream and downstream issues, but it's so difficult to measure outcomes with upstream investments. And I think that has been an issue for a long time with Ccos or other organizations investing in upstream processes. Have you given any thought about how we're going to measure success in some of those upstream measures?
I think it's funny that you bring it up because I have in my talk, you'll see glide path is the name of the game. And for some of these upstream investments, we have to start with the process, right? Like the system's not ready to start with an outcome measure. And that might be because we don't have the data. That might be because we don't have the pathways to get folks care that they need. And so you'll see that the measure that I'm going to talk about today, as well as the measure that Steph mentioned on meaningful access to healthcare, specifically related to language access, that measure, these measures are on a glide path where CCOs have to do some work in terms of the language access, doing some self-assessment work, looking at their own processes. And then there is a glide path to where we get to an outcome measure where we're looking at an individual members and seeing, okay, folks needed interpreter services, are they getting those services? And then I think there's a broader question about you're doing that thing and then, you know, outcome overall health. And so we do monitor some of those things. We have survey data where we ask Medicaid members about their experiences, et cetera. But I think a lot of another reason for having this upstream component is because some of those things that we want to do, we're not ready to start counting and start looking at that outcome piece. We have to build the foundation first. But we've been trying to be mindful in our developmental work to be able to get to that level.
Thanks. And I think that's important, particularly as you're looking at, you know, if these are going to be over the length of the waiver, the time course of the waiver. And to me, that's reassuring because I think sometimes money gets invested and then the next year priorities change and that program kind of dies. So I appreciate that. Thank you.
So lots to think about in our incentive program. Our hope here would be that, as I said, really thinking through how we measure and reward improvements in health. I will add one other thing here that's not on this slide, but is pretty substantial in terms of the impact to kids in our state. This is, if you have seen any news articles about this in the past couple of weeks, but we have had a waiver of EPSDT in our state. So that's the Early Periodic Screening, Diagnosis, and Treatment program. That's a federal program that focuses on ensuring access to screening, diagnosis, and treatment for kids in the country. And Oregon has had a waiver of that since 1994. We will not be pursuing an extension of that waiver in our state moving forward. And so that creates some change in terms of needing OHA to really build a better and more robust system for tracking appeals, ensuring that families have access to an appeal process that is not a burden for them whatsoever if they're denied any screenings or treatments or diagnostic work that we need to support. So
is this really quickly, is this the waiver that is helpful with children with disabilities and like pre-screening? Yeah, so I just want to applaud, like this is a big deal. My staff gave me the update on this, but my understanding there were a lot of children, many children with disabilities that weren't getting the treatment that they needed because of this waiver, and OHA saying, you know, we've covered it, but they weren't covering all of the pre-screening. So this is a big step in inclusion, I think. So I just applaud you for making this choice.
Thank you. And it was a community effort for sure in terms of bringing this to OHA. I think there is a challenge in terms of infrastructure. I'm not saying this is acceptable, but there is a challenge in our state in being able to understand at the community level, at the local level, what exactly is happening in terms of denials and things like that. That isn't information that we have readily available to us. So it's a little bit of us not knowing the scope or scale of the problem and what that presents in terms of challenges to equity. So our hope would be that in establishing this program, when there continue to be denials, which is a possibility still, EPSDT opens the door to a better appeals process. There is still a component of what is considered medical necessity that is at the provider and plan level. And then when that is an issue, then the state can step in a more comprehensive and cohesive manner, which means we need to build that structure within our agency to make it equitable, to have an appeals process that's an individual review. There are other pieces of this, and I'm happy we can share the press release. I think there are other aspects of this that are also important to this work beyond having a waiver or not, in terms of updating and improving how we consider some of these treatments, specifically for children on our prioritized list in the state as well.
I think workforce development is going to be a huge part of that as well, particularly in rural areas where those services are not available, not because that, and they're perhaps denied just because of the lack of availability.
There are a lot of access challenges for pediatric needs in the state. Okay, great. So the last set of slides I have briefly, if you go, I actually think I duplicated a couple slides here. So if you go forward to the blue slide, thank you. This is on our last concept around focused equity investments. So the next slide, the vision here would be that we have community-led solutions for our health inequity issues based on community-led investments. So really saying that when we go back to our equity definition that we had in the first couple of slides about the transfer of power and resources, that includes financial transfer in decision-making. And so really saying, if we want our state to be focusing on health inequities, who better to be understanding and working with it than our community-based organizations and those who are especially leading work already in this space. I included a little side set here about what is community. I think community means different things to different people. And in this instance, when we talk about community, when we're referencing it, we're thinking about local and regional partners in this work, especially those steeped in equity who are representing, serving, or are they themselves people who have experienced historical racism and oppression. But I think that may look different in different areas of the state. So we have a lot to work on in terms of building out what this actually looks like. And there's a lot more effort going forward. So let me explain what this actually means or what this is starting to look like. So if you go to the next slide, the proposed waiver strategies are to take state and federal investment and build towards a community-driven initiative to eliminate health inequities. So the vision is that there would be these new community investment collaboratives stood up across the state. These community investment collaboratives would be a collaborative of existing partners and community-based organizations. They would decide where to spend money in the community to solve health inequities. This has really been established from a vision of the regional health equity coalitions in the state through House Bill 3353, which passed last session. Some of the money would be coming directly from the state to these community investment collaboratives, and then Ccos would also be required to spend a certain amount of their budget to support these community investment collaboratives. There's a lot more work and vision behind the scenes on this. I'm happy to talk a little bit more to it. We can also send you more information afterwards. A lot of it is also unformed because there's all of these strategies require a lot more development across at least a year of work and collaboration. And now that these ideas are on paper and we hear from CMS about their concerns, we need to be speaking to people who are going to actually be implementing these. So I will pause there. Kali, I know you had a lot of questions about this area, so let's
Yeah. Well, you know, so Children's Institute was obviously a big partner in this work. And one of the things I think we've learned, and I certainly have learned in past work, is how challenging it can be to engage community. And so we can put it on plans and we can have the aspiration, which I think is very important and good. But when we talk about community and truly engaging the diversity within a given community, even in some of the geographic places that are more isolated, there's a lot of diversity and people are not tapped. I'm wondering, I guess, a few different things. How will the CCOs be supported to do this authentic community engagement? And, you know, I would add that we've heard from CCOs that while they can reach certain folks in their community, they're having challenges reaching all and really getting all voices. So I guess my first question is, how will you guys support the CCOs? We've also heard that there's technical assistance that you'll be offering through your center with no clarity on what that looks like. And so if you can bring some clarity about that as well, that would be great.
Yeah, okay, so your first question about CCOs, I will speak carefully and also maybe vaguely here, but CCOs are not envisioned to be leading this work. This is meant to be something that is at the community level. CCOs have a lot of money themselves to be doing this type of work, and we want them to leverage partners in the community who have expertise in this as opposed to building it themselves. And so while the money may flow through CCOs and CCOs will need to be some type of partner, they will not be leading the community investment collaboratives.
Okay, but if they don't have relationships with all the partners, then it's putting the onus on the partners to find the CCOs and not the other way around, which will leave people out.
Yes, I hear you. I think there is a lot more work to be developed. I think these are the types of questions that need to be asked of the group of how this will happen, because it's also really different in different areas, as you mentioned. There will also be the vision that I have seen so far has been that there would be infrastructure and capacity building grants provided to communities who don't have a collaborative ready to go in place. As I said, there's a lot more detail that I'm happy to share in terms of the initial vision that I've seen so far. That would be kind of this like 3 organization collaborative representing different needs of this work, whether that's managing the actual financial component or whether that's actually leading community engagement, that type of work as well.
Okay, and how about the TA?
So those would be the community investment collaborative grants. That would be infrastructure and capacity building.
Okay.
And then there would likely need to be technical assistance as well. There is a group that has started to convene to think through some of these questions. As I said, the Regional Health Equity Coalitions are really a partner and are co-creating this work. And so that group has been starting to come together to wrestle with some of these, like, what does this actually look like, and where are our pitfalls and the challenges, and what is unformed at this point.
Okay, well, so my last question, which is somewhat connected to all of this, is, you know, given that CCOs are not leading it, like you just said, I'm just concerned in capturing folks. And then when you look at rural areas and how dispersed communities are, how separate, like in the frontier communities, that people are from one another, I'm trying to think of how do we really hear voice and all voices. And I guess my last question is, what is the role of the council or the ELD? Like, is there something that you're expecting of us to help the partners be successful in this work and help the families and community members understand what this is and how it can benefit them?
Yeah, I love that. I think there's definitely room for a lot more collaboration. And I mean, even these types of questions are helpful to us in terms of where is this? I mean, a lot of it is unclear, so I'm not going to say that I've been clear about this, but to start to focus in what are the big questions, what are people most concerned about that we can start to wrestle with to come up with some development ideas. This is really in early stages and relies on a lot of feedback from the federal government in terms of where they are interested or concerned. And so I hesitate to say what these are going to look like because it's going to be informed by what CMS is pushing back on, or they may say, this is great, but we need you to have it all be only for Medicaid members. I'm just making this up. And so that would kind of, we'd have to rethink, what does that mean? How does that impact this work? And I think there's a lot of vision here, and we're still working on implementation. We have heard some feedback. There's certainly concerns about whether or not, what will be the interaction with Ccos or existing community advisory councils or existing health councils.
Yeah.
So there's a lot to still navigate.
Yeah, this is Anne again. I just on that point, again with my hat, my rural hat. There's so many things that are in place that. And there's so little capacity to do more. So does it really have to be a new community investment collaborative, or could you take something that's some existing capacity that's there, and get them focused on sort of the health complexity data and whatever is needed, rather than start something afresh? Because there's so few organizations that are so overtaxed. Mm-hmm. There's, that are already are trying to collaborate. And so does it have to be new is my question.
It's a great question. I don't have an answer to that. And we're going to bring all of this feedback back to the folks who are leading some of the development here, because I think they're great questions and very valid concerns. And I think, the heart of where this started with House Bill 3353 and some of the work it required us to put this into the waiver. I think there is a vision in thinking about where the money goes. If we're asking Ccos to do work in equity, we have existing partners, kind of what you're saying, that are doing this work. So let's fund them and let's make this a collective, collaborative, streamlined effort in terms of investment. It's hard. It's like really messy when we start to get into how does that actually happen? What does that actually look like? So I hear you on that. I think we have a vision, not sure exactly what it'll look like to get there.
And I would just add on this with the partners stuff. Obviously, we've got the early learning hubs that are all over the state. And also, I'm sure ODHS is talking about forming family engagement councils, I think they're called, all over the state.
Yeah.
So to Anne's point, there are a lot of ongoing and or newly starting efforts to center things around communities and families. So maybe one of the roles that the council can play is to try to pull some of these partners together. And when ODHS presents at our March meeting, I think we can ask them to also address what's this community level engagement and collaboration look like, or what could it look like?
Yeah. And Anne and Kali, I appreciate your points too. I think we are in the pendulum swing of we need everything informed by community. We're not doing that in a cohesive way, and it's creating a lot of burden on our communities. And so aware of that, don't quite have a fix yet for that, but recognize that it's a lot to ask. And even the development of this work, to say we're going to co-create, you're going to be at every meeting, is a lot to ask. So navigating that, it's new. I think it's better, but it also, we are definitely dealing with some growing pains.
Well, and I will just say it's very exciting that part of what you're thinking about is actually using money to invest in building that capacity at the local level. So that is fabulous. That is just great.
Yeah, great. Well, this is a great group. I know that this is not child focused, but I think we recognize, and what I think about all the time is obviously this will impact kids and families and these types of investments. And so really excited to be able to bring this back and talk further about it.
Okay. Well, I'm just worried we're going to run out of time. And as you know, we've got Sarah and Kate also teed up. So, but it's our fault, not yours, Steph, that we're running long.
So this is a great conversation. I love the feedback. I think I only have one slide, and it's just our timeline. Just to share with you. So where we're at right now, we're in that post-February. We just submitted our formal application on last Friday. So really exciting. 607 pages. Happy to share with anybody who wants to look at it.
Thank you for not.
And we'll be going through negotiations with CMS in the coming months, back and forth. Pieces of that may extend. We are really conscious. We work really closely with our tribal partners in this work as well. There's a number of policy and strategies that they have developed that have been put forward. And so that will also be on its own timeline. Our current waiver ends in June. July, the new waiver is accepted technically. We then spend the rest of the year working through contract changes, rule changes, all kinds of aspects of that. And then the new contract year starts in January. It is likely that even if we got all of it, it's not going to all start right January 1st. There will be a stagger. We need to build a lot of the capacity. We have a lot of questions still. So just for people's awareness. So with that, my time is done. Thank you all so much. You are always welcome to email me if you have questions, ideas, or feedback. And Remy, Sarah's slides are actually attached right after that. So we can just keep going with the same slide deck.
Yeah, sounds good. Sarah, thank you Steph, sorry. Thank you so much. Obviously, there's a lot of interest among the council members in the waivers. So we'd love to just keep updated as your negotiations proceed.
Yes, absolutely.
Okay, thanks, Steph. And welcome, Sarah, again. If you would just introduce yourself for our records, Sarah, that would be great. Thank you for being here.
Sure. Good morning, everyone. Thank you so much for the opportunity to talk with you today. My name is Sarah Kleinschmidt. I use she and her pronouns. I am a senior policy advisor at OHA. I work on healthcare quality measurement, and a lot of my work focuses on Medicaid and Ccos specifically. Wait for my slides, one moment. So today I'm going to talk about some measurement efforts related to the health sector's role in getting children ready for kindergarten, and specifically work related to improving the social emotional health of young children. I welcome questions throughout. I'm happy to keep this informal and make it a conversation as well. I will ask for your help. I can't actually see all of you as I'm presenting, so if there's a hand raised, I may not see it, so if folks can call that out and let me know, I appreciate it. We can move to the next slide, thank you. So before I get into any details, I have to acknowledge that the entire health aspects of kindergarten readiness strategy work that I'm going to talk about has been developed over several years in partnership amongst Children's Institute, the Oregon Pediatric Improvement Partnership, and OHA, with many others involved. So some of the slides that follow, some of you will have seen in presentations to the council from our partners. And just tremendous gratitude for the social emotional health measure work I'm going to talk about today is really due to Children's Institute and the Oregon Pediatric Improvement Partnership for their leadership in developing this measure over the last couple of years during the pandemic. And final note, I would also be extremely remiss if I didn't call out the support of the Early Learning Division, particularly David Mandel. David joined us as we developed the social emotional health measure, and he was very giving of his time and expertise. So much gratitude. Thank you, David. I know he's on today. So as you've been hearing about, there are lots of ways that we focus on early childhood health at OHA. We know that health and well-being are very complex, that they require many different levers to affect change. And so the lever that I'm going to delve into most deeply today is our Cco Quality Incentive program. We monitor Ccos on a whole host of healthcare quality measures, but Ccos earn bonus funds for how they perform on the measures that are included in our Cco Quality Incentive program. The program currently includes 14 measures. You can see some of them on this slide. And for the most recent year of the program alone, altogether, the Ccos will be eligible to earn over $250 million if they do well on the measures included in the program. So it's a real big carrot. and we know that CCOs really focus on the things that are included in the program, so therefore what is included is very important. The program now has 3 measures from the strategy focused on what the health sector can do to get kids ready for kindergarten. And so I'll give you a history of how we got to that point today and then where we're going. Go to the next slide. The Metrics and Scoring Committee is the public body that chooses what is included in the Cco Quality Incentive Program. And that committee has, for quite some time, been interested in what CCOs can do to improve kindergarten readiness. So at the committee's request, a technical work group was convened in 2018 to recommend and develop health system quality measures specifically related to what the health system could do to improve kindergarten readiness. And that included thinking about measures that would drive behavior change that will contribute to kindergarten readiness and that catalyze cross-sector collective action. Cross-systems work was very important in thinking about this. So when our partners at Children's Institute recruited work group members, they intentionally sought a real diverse cross-section of representatives. So the work group had 15 members. It included key healthcare stakeholders or primary care providers, CCO representatives, as well as consumer representatives, as well as folks from early learning. So including early learning hubs, as well as early learning program representatives. And that work group was supported by partners at OHA, Children's Institute, and the Oregon Pediatric Improvement Partnership. And this next slide shows the work group recommendation, which was a multi-year, multi-measure strategy that you can see on this slide. The visual shows the recommended glide path that includes multiple measures that roll out over multiple years and that collectively improve children's physical, oral, social, emotional, and developmental health. Now on the left here, you can see that in 2020, 2 measures were added to the Cco Quality Incentive Program as part of the strategy. The first on well care visits for children ages 3 to 6, and then a second measure on preventive dental visits for children who are aged 1 to 5. You can advance for me. Thank you. And rather excitingly, just this year, the next part of the strategy, the system level measure focused on children's social emotional health was added. Social emotional health was one of the key things that we heard from families as important in getting their kids ready for kindergarten as we embarked on this work together. So we'll talk about this measure specifically more in the next slide. So the system level social emotional health metric that was developed has a very broad vision to ensure that young children have equitable access to services that support their social emotional health and meet their needs. And given the complexity of social emotional health, as well as the complexity of the healthcare system, the measure has been designed to drive CCOs to address system level factors that impact services to kids and their families. We move to the next slide. This goes more into the glide path. So this measure is a glide path. It has multiple components that you can see here on this slide that build towards improving the provision of social emotional health services over multiple years. So CCOs will meet this system level social emotional health metric and therefore are eligible for those incentive funds by doing these 4 things. So in the first component, they have to review a report from OHA on social emotional health assessments and services that we will provide to them in each year. So in January of each year, OHA will send a report with information on young children enrolled in a CCO to that CCO, and it shows whether they have received social emotional health assessments and services. And CCOs have to review these data, this report, to understand gaps in needed services, to look at whether there are disparities for different populations, et cetera. The second component involves developing an asset map of available social emotional health services in their area. And I'll go into that in a bit of more detail on the next slide. The third component is engaging partners to identify services and gaps by reviewing the report from OHA, as well as that asset map that the CCO put together. And then finally, developing an action plan. So you can see on this slide that component 1 reviewing the data from OHA on reach of social emotional health assessments and services, and component 2, creating an asset map of social emotional health assets and service gaps, feed into that third component, which is about engaging with community partners about the data, about assets and the gaps, and really talking about what their local priorities are for improvement. Those components then lead to the right, the fourth component, on the creation of an action plan, which the CCO will have to co-create with community partners. On the next slide, you can see that glide path, as I mentioned earlier, is really the name of the game, both for the overall health aspects of kindergarten readiness measurement strategy and for the components of this specific measure and the behaviors that it's meant to incentivize. This slide gives an example related to the asset map component of the measure. So the asset map that CCOs have to complete builds over subsequent years, beginning in the current year, 2022. So this is the first year in which this measure is included in the program. So in 2022, over the course of this next year, CCOs need to assess capacity and characteristics of specialty behavioral health referrals. So if a child is assessed by a primary care provider and that provider finds that the child needs to see a behavioral health specialist, is there a behavioral health provider with training for young children to whom the provider can refer that child? Then in the next year, it builds. So the CCO will need to update what they did in the previous year, and they'll also need to look to internal referrals. They have to assess the capacity of integrated behavioral health in primary care. So is there someone in-house from whom this child can receive needed services? And then in 2024, it builds further. So CCOs will need to reassess what they've done in the previous 2 years, and then also look and assess the capacity and characteristics of community-based social emotional supports. So just like the asset map on this slide, the action plan that CCOs will need to create with community partners will also be revisited each year and build and grow over time before we would get to what we had talked about previously, outcome measures, and before we would get to a child level metric. In all of this, there is a focus on cross-sector collaboration. And this is really an explicit requirement in the measure. So in each year, CCOs must engage cross-sector community partners to review the data on access to social emotional health services that I mentioned that OHA will provide to them each year, and also to review the asset map of social emotional health services and providers that they have. CCOs will have to discuss barriers and opportunities to improving social emotional health service capacity and access with these cross-sector community partners. And then in each year, the CCO has to partner with folks from their communities and their service areas to co-create their action plan.
Can I have a quick, sorry.
Sure.
Can I ask a question, Sarah? Can you go back to a slide? So the thing in 2022 around assessing capacity and characteristics of specialty referrals, you mentioned that they would assess and figure out where to refer. The CCOs would assess and figure out where to refer a family. Is that, am I understanding that correct? Or no?
So they're not looking at an individual family, they're looking at the higher level.
Their whole
so the
system.
CCO needs, yes.
Yeah.
Like,
so
do we have contracts with behavioral health providers who
got it.
Have training for 0 to 5?
Okay, so we've been doing as a council these listening sessions, and we've done them across a few different communities. And I know both within the listening session in the Black community and the listening session that Peter did in the Southern Oregon community, there was a lot of bias that showed up with providers. It's like the families felt that they were being judged. They didn't feel that they could even begin to address the social emotional needs because there was judgment being placed on them. And I'm wondering, what is your filter to ensure that if you assess in the system that you have these providers, but there's no filter to ensure that those providers are actually providers that community trusts, then it doesn't necessarily give more access to social emotional services. And so I'm just wondering, like, how you're addressing that issue, and if you've seen it come up perhaps, because we definitely that was like one of the things that was the same with both groups. And there's clearly a feeling of the current providers don't respect families.
Right. And I'm not getting into the minutia of the measure, but in the asset map, for example, one of the things that the CCOs have to look at is when they're listing providers, they're looking at, what languages can this provider provide services in? What is the race and ethnicity of these different providers? What does their population look like? And is there a discrepancy between the race and ethnicity or languages of the providers that they have and what their population looks like? And that's, I think, part of the conversation in that third component is looking at this asset map with their community to be able to raise those exact concerns that you're talking about, to identify that, okay, well, we have all of these slots, but potentially for a specific community, those slots don't actually mean access. And what are we going to do about that? And then the final thing I'll note is there is requirements within the measure to identify priority populations in each year as well with community. So they will be required to think about these things moving forward. I think you raise a really important point that slots don't equal access, and the measure has been designed with that type of thinking in mind. But certainly, we may get feedback as we move forward for changes that might need to be made.
I have sort of a follow-up on that too. How broad is the, when we talk about specialty behavioral health referrals, I think oftentimes these are families that would be better served working with, developing relationships, like working with a relief nursery or in a quality daycare program, as opposed to working specifically, let's say, with a behavioral health therapist. So are these referrals going to be broad enough to include things like home visiting or referrals to relief nurseries, that sort of thing?
Yeah, so it kind of starts with things that would be reimbursable, right? Like those things, specialty behavioral health, but that's part of why it builds, and thinking in that 2024, that third year, looking at capacity of community-based social supports that might be a better fit. Just thinking about back to the purpose and the intent of the measure is that families have access to services that are a best fit for their needs. And that is the reasoning behind having this glide path, and not just looking at the things that are immediately reimbursable, and also having CCOs think more broadly about their payment policies and whether changes that they might be able to make to better fit the needs of their members. I agree, it's a really, really good point. Any other questions?
Okay, we better keep going here. Yeah. Thank you, Sarah.
No problem. I can go through these last slides quite quickly, actually. So that was your very brief overview of the social emotional health measure. And I started my part of the presentation today by noting that health and well-being are really complex, and they require lots of different levers to affect change. And while the Quality Incentive Program is a pretty powerful lever, it's going to take a lot more than that to achieve our goals. So I want to briefly speak about another effort that will give further attention and catalyze work around social emotional health, which is our current CCO performance improvement project. The Centers for Medicare and Medicaid Services require states, and in this case CCOs, to work on focused performance improvement projects. And these projects are meant to improve quality of care both in clinical and non-clinical areas. And while there are not dollars tied to performance, these projects include interventions to reduce barriers and improve care, and they require measures to track progress as well. And OHA provides a lot of support to CCOs for their performance improvement projects, and there are federal requirements in terms of performance monitoring. The next slide shows you more information on our current statewide performance improvement project that all CCOs must work on, and that actually focuses on access to mental health services. This focus on access to mental health services started in 2021 and it will continue through 2023 for all CCO members ages 2 and older. And while it's not specifically 0 to 5, we think that this is a really important and overlapping work that complements the health aspects of kindergarten readiness, social emotional health measures. So we wanted to just make sure that you were aware of that. Next slide. We are also very lucky to have our Transformation Center, which it's really our hub for innovation and quality improvement for the health system in Oregon. And the Transformation Center has been supporting efforts around both the Performance Improvement Project as well as the first 2 measures in the health aspects of kindergarten readiness measurement strategy, and is also supporting work on the new social emotional health measure. This slide just gives you an example of some of the types of technical assistance that the Transformation Center has provided for the health aspects of kindergarten readiness measure on well child visits for 3 to 6-year-olds. Just an example of some of the things on offer.
Hey, Sarah.
And
aligned with that, what is the TA? I mean, it's similar to what I asked before. What are you doing on the social emotional health metric? What is the Transformation Center doing?
Yeah, we have had needs assessment. We start all of our process by having a needs assessment calls with the CCOs to understand the types of technical assistance that they require. And so we have had 2 of those. We have had a webinar explaining the asset map. We created a fillable version of the asset map and have had a couple other webinars for CCOs with Lori Theodoro, who is a licensed clinical social worker on our staff, and are currently planning a learning collaborative as well. And that's just a bit of it, and I suspect that the Transformation Center will plan other things as well.
Okay.
If you want to go to the next slide, this is my last slide. And I just wanted to close by highlighting our 10-year goal to eliminate health inequities. And just note that we see the measurement work that I talked about as really integral to that goal by helping us to get upstream to address really the fundamental root causes of health inequities. And with that, I'm happy to pause for questions, or I know time is of the essence, so I'm also happy to turn over to Kate too.
Thank you, Sarah. Great presentation, very exciting work. Oh my gosh, council members, questions or comments, feedback for Sarah from your perspectives? Yes, Peter.
And Sarah, I was just going to ask on the vision, it says from pregnancy to age 5. Was there any ever consideration? I'm sorry, it says from birth to age 5. Was there consideration of making that pregnancy to age 5? Because the data shows that a child's behavior health development starts in the womb.
Yes, the work group did discuss having some focus on prenatal care as an example, but in the end decided to highlight the measures that I showed you all. But yes, you are right, extremely important.
Okay, other questions or comments from anybody? I know the Transformation Center has been doing great work for a number of years, so it's exciting to just to see as that progresses and is looking at the kindergarten readiness piece as well. So great partnerships all over the board. And we want to thank OPIP. I know that's Colleen, and I know at the Institute, it was Elena doing a lot of that work. So we appreciate all of the partners sitting at the table. That's very exciting.
I have one more comment just in what I understand about the social emotional metric and the CCOs. This is similar to what I said earlier, the community engagement piece being really critical there too, and having different barriers in ways, because anything dealing with social emotional health and mental, which dovetails into mental health, has a lot of different things attached to it, schema attached to it. So I think to the degree that OHA can be clear on the transformation center supports, I think, and this is maybe a little selfish, like we are engaging with CCOs on this issue at CI and want to be respectful of the transformation center and what you're planning on doing, but there's not clarity on what that is specifically on the community engagement part. And so to the degree that you can lift up and how it intersects with equity specifically, I think would be helpful. All the equity things you outlined earlier.
Yeah. George.
I think I was kind of in the same mindset of Kali, and I just feel like recovery and bouncing back is going to take a long time. Like I know I experience a lot of disillusionment on a daily basis from kids or from parents. Even when we say it's, masking is going to be optional, they're just mad that we still haven't done it, or they're just mad that we did it in the first place. There's a lot of things going on. And so I'm going to say people are not regulated very well. And whatever we do with agencies, we should probably do more things like, I'll just say with private agencies and public agencies and faith centers and parents or neighborhoods and nonprofits. Like there's going to be a lot of things that we should be doing to build resiliency or build regulation. And whatever we do at an early learning council or early learning level, we should really look at what's going on in children's lives, older than that, and then also even into adults. So that's what I'm hoping, that there's a thinking of that way, or that support, so that in general, we can find meaning and purpose as we recover through COVID, through a pandemic. So there you go. There's my 2 cents.
Yeah, well, I'd say that's more than 2 cents, George. And you're right. You're right. We see that everywhere in every sector and every community, and it's going to be with us for a while, however long. Okay, Sarah, thank you so much for being here today, but also for all of the work that you're doing in this very important field. We appreciate you a lot. So thanks. And now we will move to Kate, whom we all know well because she sits on the council periodically. And we're delighted to have you, Kate, and as well as Lisa Harnish, whom we've all seen before also as the director of the Early Learning Hub in Marion Polk counties. So welcome, Lisa. Thanks for being here. And Kate, I will turn it over to you.
Sure. Thanks, Sue. And like Sue said, I just want to welcome Lisa. We're partners on this from the state level and the local level, and we hope we can give you a picture of where we are in implementing the University Offered Home Visiting the Family Connects Oregon. Remy, I think you've got our slides. Awesome. I am going to kind of go through this first part quickly. It's just a reminder of what this program is. So we know that this is an initiative to strengthen families by offering a voluntary home visit by a nurse shortly after the birth of every child, because entering a birth of a child, whether it's your first or fourth or whatever, is a big change for any family, and families need different kinds of supports at this transitional and transformational moment. And so this model really helps to connect families to those services that allow them to be able to realize a really strong trajectory for their newborn as well as the family itself. And by that way, we have better health outcomes, better community health outcomes. And just as a point of note, this is a Raise Up Oregon Plan objective number 8.1. So we are connected to y'all in a really strong way. I forgot to, in the first slide, just acknowledge our partners in this journey. The Early Learning Division, clearly, the Department of Consumer and Business Services around the Commercial Health Benefit Plan work, our partners at the Family Connects International, and of course, at the local level, everyone doing all of the really hard work that's putting this really into place. Next slide, please. So we know that the goals are really ultimately to create and strengthen this community level system of care. And so this harkens back to the conversation we were having with Steph around the importance of community and community implementation. The beauty of this model, as we'll talk about in a minute, is that it is community driven. And so while we're right now at the point of standing up just the structures, we are looking forward to actually strengthening and supporting the community driven changes and developing that community system of care that's best for the families that live in those areas. So it offers support to new parents and promotes the collaboration and coordination across early learning and home visiting systems. Again, I think we've got a community advisory board that's required for this model, as do many other. How do we collaborate and coordinate all of those different entities that are trying to pull in the different voices to strengthen what's happening at the community level, ultimately to improve health outcomes. Next slide, please. So just as an anchoring, Senate Bill 526 of the 2019 legislative session was passed. It directs OHA to design and implement this program, and it requires the commercial health benefit plans to offer this to their members and reimburse in full for those services. Next slide, please. The Family Connects model was chosen because it currently is the only model that meets the letter of the law, the statute. It is an evidence-based model. It is a nurse-based model, and that's pretty important because at this brief intervention that we're being offered to families about 3 weeks after the birth of the child, there are nursing assessments that go along with that. So it's the nursing assessment, but it's also then the social, emotional, and the family assessments that go into this point of contact with families. Next slide, please. So the model is really quite elegant in its simplicity. These are the 4 required elements for fidelity that it's offered to everyone, that there are no additional costs to the recipients, so no out-of-pocket charges for families to receive the service. It happens about 3 weeks after the birth of the baby. This is kind of the halfway mark between that 6-week postpartum checkup that families, that birthing parents and their newborns often get. So it's at that point where the relatives have gone away, the supports maybe aren't quite what they were at the excitement of coming home for the first time, and some real support. Families could really use some support right about that time. And like I said before, that it is a registered nurse. Next slide, please. In order for the model to get the outcomes, there are 3 components, of which the home visiting portion, it's called a home visiting program, but that's one component. The real strength is having that community alignment among the different partners and services at the local level, and then ensuring that we're collecting the right data so that we can do continuous quality improvement, so we can understand what's happening in the community and are the services there to be able to support and serve the families within the community. Next slide. So in the 21-23 legislative session, we got additional funding. We now have 7.8 million in general funds. So that was current service levels from the 1921 biennium, plus some additional funds for this current biennium. The funds support the state level staff. They pay for the provider services, primarily the Medicaid match for those families that are on Medicaid. We have contracts that this supports, and then we put money into supporting the local level initiative for the implementation. Next slide, please. This is our team. I will say I really admire this team. They have been through thick and thin through COVID. We've lost some team members, we've gained a few. This is also reflected, I think, in the early learning division. Our partners there have lost some members, gained a few. All of this within the context of COVID. So this is who we have at the moment for our team. Next slide. And this is our partner, Deja Street Davis from the Family Connects International Group. She has been designated by Family Connects International to be Oregon site director solely in her portfolio. So that shows the level of importance that this is also for that organization. Next slide, please. So the journey so far, if you remember, we started off with 8 early adopter communities. I do want to just recognize that the reason we're doing early adoption is so that we can learn all these lessons. And we have learned a lot, and we have a lot more to learn. And I try to remind our staff, don't be afraid of things that don't work or bumps in the roads or challenges, because that's the whole point of this phase of the implementation is we want to learn as much as we possibly can. And probably one of the first learnings is we took on more than we could chew with 8 early adopter communities. And COVID, sadly, next slide, please. This shows you the geographic diversity within those 8 early adopter communities. I mean, we really bit off a third of the state geographically to try to learn about this program. As COVID took its toll, we now, in the next slide, are down to a lot less. So within this, Clatsop County decided to wait. They were going through some leadership changes and just could not take this on at this time. COVID really took a toll on all these communities, but in Eastern Oregon, the Eastern Oregon Early Learning Hub, those communities, we really just didn't have the capacity to be able to do this. There are some unique challenges also in the more frontier counties in terms of the local infrastructure that's required to implement the model to fidelity vis-a-vis the number of births. And so the revenue streams isn't enough to support what's required. So we're trying to rethink in the more frontier counties, how can we make it a viable implementation, and we will get there. Lane County also needed to wait until they've got more on their feet post-COVID. So currently the active counties or communities are Central Oregon, the Lynn Benton Lincoln area, Marion Polk, and Washington County. Those other 3, so the 4 Rivers area, the Eastern Oregon and Lane County are paused, and we're hoping to be able to re-engage them sometime in 2022, early 23. We've got some things that we need to crack, some nuts we need to crack before we feel comfortable bringing them back on. Next slide, please. So this was our timeline. I might even be adding yet another phase onto this because we just are learning so much, and we can't go forward until we've really solidified some of these pieces. But we are approaching the middle of that second green bar. I will say this was ambitious. This was before we really knew what we didn't know. We are standing up something that has never been done in the country. And so I'm just trying to give us all grace and really focus on what we have been able to achieve. And by going slow now, I think we'll be able to go faster as we move on to subsequent cohorts.
And Kate, let me just insert, I think, never been done in the country. Is that because nobody else decided to roll this out statewide?
Correct. Yeah. Now, we are the first to have legislation around it and really the political will to do this. I mean, I will say the legislature has been very generous with supporting this program, and I feel very grateful for that. New Jersey has some legislation, as does Connecticut. So they're in the early stages of what their implementation will look like. So, and then there are other pockets like the city of Chicago, which has the same birth population as the state of Oregon. So there are other places that are doing this, but not statewide like we are. And I think some of those challenges are, we've got such a geographical diversity. We've got urban, rural, frontier. We've got lots of different systems that are working together on this, from public health to early learning to trying to bring in Ccos and the community-based organizations. So there's a lot of moving parts with this, and the commercial health benefit plans.
Any one of those would be enough to sink the ship.
It's a lot, but we're doing it. So next slide, please. Okay, so let's focus a little bit on what's working well. Our early adopter communities are determined and dedicated, and I just want to do a shout out to them. They have been through thick and thin. We've launched these 4 sites during a pandemic. We've had some strong relationships, like in Washington County with the hospitals, and we'll talk a little bit more about why that's important. But I just can't say enough about the tenacity and of these early adopter communities, and I thank them from the bottom of my heart. While it feels like 245 families may not be a lot, it's actually quite a lot given everything we've been up against. We are serving right now only Medicaid families, which is not part of the model. The model is universally offered, but the Family Connects International has given us this grace while we work through what it's going to take to get the commercial health benefit plans on board and starting to reimburse for these services. So you can see where we're serving families. Some counties have worked out some of the details a little bit better than others. So we've got some very specific challenges to work through that I think Lisa will touch on a little bit. And after we sort of work through these, I think we'll have a model for them being able to replicate processes and procedures that will work better across other communities. The post-visit calls with families that have actually completed the full program, all the families have reported that Family Connects, the experience was helpful. So that's great. That's what we hope for. That's what the model promised. And so it's really great to hear that. Next slide, please.
Can I ask a quick question?
Yeah.
Okay, and I apologize if I missed this.
Yeah.
What was the ethnic diversity of those 245
families? I need to get that information. I do not have that at the tip of my fingers, but I can get that. I just can't even speculate really. And maybe Lisa might be able to touch on that a little bit more from the Marion County experience. But I will get you that information.
Okay, great. Yeah. Thank you.
Yeah, this is an area that we've really not had the bandwidth to focus on, and I'll share about some ideas that we have, is really focusing and elevating outreach to some of the more diverse communities. I know in Lynn, Benton, Lincoln, they've done some specific outreach to some of the Guatemalan communities and trying to get some of all the materials and trying to get providers that speak those local languages so we can better access them, provide access. So we do have a statewide medical director, Dr. Ben Hoffman, who also now sits on the HERC and is also our Title V Children and Youth with Special Health Care Director. So he's touching us in lots of different ways, which is great. And at the local level, each community has a clinical champion that will help to drive improvements in the clinical parts of the model. We have been doing virtual visits in the era of COVID, and I applaud the nurses for making that transition really quickly. We certified the programs at the local level, which is great. I would say one of our big accomplishments was upping the Medicaid reimbursement so that it includes both a reimbursement for the clinical aspects of the visit as well as the case management activities. So it's getting up much closer to what a break-even point is. Medicaid typically doesn't pay what it costs to actually do all those services, but they will be reimbursing about $1,050 per family served. The most recent budget analyses are showing that the break-even point is about $1,200 per family served. So we're pretty close on that. And we're going to be working with the commercial health benefit plans to make sure that they're covering it in full. We have a year one evaluation and a response plan that we can share with you that's been really helpful in helping us figure out what our next steps are going to be. And then we've had some really nice outreach and communication tools, and I can show those on the next slide. So here's our brochure and our website, and each site has a specific link to their website off of this main one. Next slide, please. We also have videos that we've been able to put into multiple languages that you see here, and that was based on a video that was done in one of the Texas sites. So we're trying to do outreach among using some language diversity and hopes that we can reach folks. Next slide. So our challenges. These first two are the ones that I think if we can crack these nuts, we will be in a much better place to move forward. The first one is the commercial payer reimbursement. As we got going into that, we realized that the original legislation had some contradictory language. So currently in play is Senate Bill 1555. It's passed the Senate and is in committee right now in the House chamber. It's a technical fix that will allow OHA to have the authority to be able to create the full reimbursement framework for the commercial health payers and to work with them in terms of how that reimbursement happens. So we're pretty excited about that. The other part that's really challenging right now for us is really reaching families to be able to offer the service, what we call the recruitment or the outreach. Typically this happens bedside, if you will, in the hospital. And we just have not had the access to the hospitals because of COVID, but also because we have a couple, for example, the Healthy Families Oregon program is in the hospitals, although they've been having challenges with COVID about being in the hospitals. So it's about working together with the other home visiting programs to be able to create sort of a recruitment that is a win-win for all home visiting programs. And so that community alignment and coordination among the home visiting programs is another piece that we're excited. We've got some new energy around it and hopeful that we can get that smoother and those processes ironed out. We've had a lot of turnover, just lots going on with our staff capacity and not realizing how much and what we need for that. So we're working on that. And then I talked about pausing those 3 early adopter communities till we iron out some of these other challenges. Okay, next slide, please. Question about how the council can help. We talked, I think a while ago, at least Sue and I have had some conversations about cultivating some sort of a forum around which we can cultivate the coordination among the home visiting programs. The real vision, I think in some ways, is that universally offered home visiting is the umbrella under which we have the different programs, and trying to create a space where it doesn't matter probably for families whether they're an HFO or Babies First or what it's that we want to offer this to everybody. And so how do we support that coordination so that we aren't tripping over each other and we're really leveraging each other's strengths. We will be having a rules advisory committee for 1555, and that will be interesting with the commercial health benefit plans. So stay tuned. We may be asking for some support on some of that. And then, of course, we're going to be putting together our 2325 policy option package ask. And then one thing that's really important, I think, at the local level, you as council members each represent a region. Just connecting with your communities that are doing this work and letting them know that you understand them, hear them, want to support them, and what those specific supports might look like. So, next slide, please. Now, let me turn it over to Lisa to share what it's like on the ground.
Sorry, I have one more question. I thought you were almost done with the show, but not show, but you know what I mean. So I guess I'm wondering if you have a comms strategy, because what I know, I can't speak for all communities. What I know has been an issue sometimes in the Black community is the fact that people are being targeted. They don't think they're good parents and judgments being made. And so this idea of universality, that this is not for a particular group, but it's for all, I think is really important. But the message, I don't believe, is out there. So I'm wondering, how are you communicating this whole strategy to the world? And maybe this is also an area where the council can help, but it feels really important in order for this to work. I also wonder how non-subsidized, I guess, families would even know about this. Like, will the provider just tell them, and how do you make it so they feel like it's for them and not just for, particularly because you're starting with people on OHP that, I don't know, there's a lot of layers to it. So I feel like the comms piece is really instrumental to make it work.
It absolutely is. And it was this, we did a balance, because you don't want to generate too much excitement and awareness about it if the service isn't available yet. And so I think that's where we've been holding back a bit. It's just, we need to get it sort of anchored and making it so that it is accessible to, or available resource-wise from everybody. But we do have some of the capacity that we're going to be building in is a community alignment specialist, which will specifically work with communities and the community's alignment leads on that outreach with populations within the community strategies. We're going to be hiring a health equity specialist that will be working alongside communities to how do we outreach to different community populations within the community. So that's very much on our radar. You've touched on a really key piece, and where that will be part of the next phase once we crack those other two nuts, because there is that danger that if we create buzz about it and then people get to the hospital and it's like, but it's not available to me, then that's even more damaging than if you had waited a little bit and then start to make those connections with the populations. If that makes sense.
Yeah, it does. Thank you. I think the last thing I would just say is having culturally specific providers is really important on this one, because there are many people, I think, across different groups that don't want other people in their homes when it's like the home visiting, not the virtual version.
Yeah,
that's an issue. So.
Yeah. So the other piece, the pillar that we don't have on our team yet that we're going to be asking for is a workforce development specialist who will be working. I mean, I think I've said this before. One of my visions is that we find community health workers that are trusted in their communities and help sponsor them to get their 2-year RN degree, which is what is needed for this model, to then be able to go back into their communities and have a job and be able to support their communities. We haven't had the capacity to realize that yet. So that's a specific role that I'll be asking for in this next biennium.
That's great. And I think it's not a stretch to also say that for, I think, low income families, regardless of race, there's a fear of judgment and assumptions. And so there's like, people just need to be trained on how to do this well and not come across as judgmental, I think at a very base level. So
absolutely. Absolutely. Thank you. That's on our radar, but it's always helpful to hear it again. So.
And I would just add, Kelly, that I agree. I think it is universal across communities and not necessarily people that have experienced the home nursing, the availability of home nursing, but I have trouble selling it to families. And part of it is, I think you're right, that it has been offered primarily to families that are perceived to be at risk. And even though I am trying to promote it more now for all first-time moms in our community, I get very low acceptance. And I don't think it's related to COVID. I think it has more to do with people not being comfortable with other folks being in their home. And whether that's because they perceive that they're going to be judged or they're worried about some kind of intervention. I would love to have a better script on how to sell the home visiting, because I think it's such an important program. But I am somewhat frustrated by that.
Yep, absolutely. And that's part of the clinical champions role, is connecting with providers. And so we're developing that capacity to support specifically the provider community in that work too. So Lisa, do you want to, because I think you're nodding as if you're like, yeah.
I know, I'm like, all right, let's go. This is exciting.
All right, go for it.
Oh, goodness. Well, everybody, thank you so much for having me share some of our experiences with Family Connects. I get so excited about Family Connects and the possibility that it has, not only for our region, but also most importantly for our state and for children and families. So for those of you who I haven't had the pleasure of meeting, my name is Lisa Harnish, and I'm the Executive Director for Marion and Polk Early Learning Hub. And it has been a pleasure to be in this role for the last, I cannot believe it, but 8 years almost. And so being able to see and watch not only the hub system grow, but also the early learning system grow as a part of the work that we all do. And I just appreciate the council for your guidance in that. And, you know, the hubs are here to help be sort of a sounding board for you, as well as just to give some offer of feedback of how things are going. Kate asked me to share about how things are going for us in Family Connects. So I'm come today prepared to share a little bit about where we are from an implementation standpoint, but then also to identify some of the successes and some of the challenges. And I think you'll see that I'll be talking really in alignment with exactly what Kate was sharing with you. Many of the strengths and also the struggles that we have had really do mirror what's happening at the state level as well. So Remy, you can move to the next one. So just quickly, in terms of where we are in implementing Family Connects. So the Marion and Polk Early Learning Hub brought together our public health partners in Marion County and Polk County when the opportunity came about to apply to be an early adopter community, and said, okay, what's the opportunities here? How should we approach this as a region? And it was, I just was very pleased in that very early day of being able to, the community said, we really need and want and value having that acute community alignment and having the hub serve that role. So it's been great to be a part of the implementation of this as that community alignment specialist role. And I just want to underscore what Kate was saying earlier about how important that is. And I think it really does play a big role in implementing Family Connects. So we work alongside with our public health partners in Marion and in Polk County. Currently, all of the newborns covered by Oregon Health Plan who live in Marion County are being offered Family Connects. This is being done virtually through telehealth, unfortunately, but you will see a recurring theme here is COVID and the impact of COVID. But our Marion County partner has nurses, bilingual nurses, English and Spanish, who are available to provide these services. Polk County, at the onset of the pandemic, and of course being a public health entity, was dealing with the effects of COVID, and we're being pulled in so many different directions. Polk County actually asked to take a pause while they deal with some of the staffing and all the infrastructure needed to be able to support COVID. So while they're not up and running, they've been along with us and are now in the process. They have said, okay, we've got things pretty well settled, and so are in the process of hiring a nurse. You'll see in just a moment that has also been a bit of a challenge for just in terms of hiring nurses. We also have a community advisory board that guides us in our work. So I convene the community advisory board. We have all sectors represented on our community advisory board, including social services, early learning, health, education, housing, and culturally specific organizations, as well as family members as a part of our community advisory board. This has been incredibly helpful to us to really tee up and modify the messages. Callie, I agree 100% that communication is really key in how we're promoting this to families. They've been instrumental in helping us outreach to a variety of different partners. We've been able to, through the community advisory board, springboard out into making presentations to organizations to talk about Family Connects, what it is, how families get connected to it, and also the value of Family Connects. We've also been able to modify using some of the springboard materials that already came to us as part of Family Connects, and being able to contextualize that and put into different languages for our community. Obviously, as already mentioned, we are doing things by telehealth. I have to think that that has a big impact on our uptake of people saying that they're wanting to have a telehealth visit. And or often, people will have them scheduled, but then it's pretty easy to ignore a Zoom call, or you might get distracted or that kind of thing. So that's been one of those challenges. However, it has been nice to be able to have that as a vehicle to be able to offer the visits. This for us here locally, like Kate mentioned, Family Connects is directly tied to Objective 8 in the Raise Up Oregon plan. And also here locally, we see this as a way for us to really hone in on Objective 7 and also 5, which is really about providing access to physical health, social, emotional, and also mental health services. So thinking about those referrals and how those pieces are. So for us, this has been a great springboard into those specific areas. You can go to the next slide, Remy. So in terms of, and I've already mentioned a little bit of this, in terms of some of the outreach and marketing, we work with a wonderful communications group on our website. And have worked really hard to make that an easy place for families to go. So we have created a page on our website and are pushing traffic towards our website, where we have information available in English and in Spanish. And we're also working on translating materials into, likely it will be Ccos or another Micronesian island language, and then also Russian. So that families will be able to see their languages represented. But on our page, we talk about what—
Lisa,
Yeah.
sorry, this is Sue. We have like 3 minutes.
3
left.
minute. Oh man,
Yeah.
I knew that was coming.
So, and
So
I
we also—
apologize for that, but if
No,
you
it's all
can
good.
move to the challenges,
Yep.
or that would probably be really
Yes.
helpful.
All right. So some of the challenges that we have are around staffing. Hiring nurses right now is really challenging, really challenging. We're seeing that in a lot of different professions, so it's not unique, but particularly in public health nursing, salaries are generally lower. So if in hiring nurses, it's often easier to do them in other clinics. Also, schedule flexibility and those types of things that aren't really available in our public health setting. So that's a very real thing. In fact, Polk County has had like 3 failed recruitments for their staffing. So it's very, very real. Also, the implementation of the model itself, and Kate's touched on this, so I don't need to belabor this, but it has been quite a journey, sort of, and of course, it's with the pandemic being what it is, it's really hampered that. But not having all of the insurance kinks worked out with private insurance, also getting the kinks worked out with the Oregon Health Plan and be able to bill for all the services, that has been a challenging. Also, we've mentioned it already, but some of our biggest concern about doing it just for Oregon Health Plan families was the stigma that would be attached to Family Connects. That's a very real thing. And I think we need to continue thinking, not only here locally, but with the state, on how do we message this so that it does not become one of a program just for certain families in our communities. And then also, Family Connects is an evidence-based model. It's an amazing model. And there's fidelity to that, and really respect that. And oftentimes from a community lens, like how do we contextualize that so that it really does fit within the community? And I think that that would be something in terms of thinking about the council support, like how can we make sure that we have that ability to contextualize it? Also, some of the workflow challenges have been presenting themselves in large part because we are only for Oregon Health Plan. As an example, to exemplify this, our hospitals are not wanting to really talk about this because it's not universal. And so that becomes a bit of a challenge for us locally in inviting other partners to help us share that message. They don't want to think about like, who's this for or not for? That's adding a bit of a burden. And then also that hospital relationship and building that in part because it's not universal, but then just making sure that we've got a smooth relationship with our hospitals. And then of course, COVID-19. So I won't belabor those last two pieces. I will say we have an amazing relationship with our Healthy Families organization who currently is in our hospital setting. So we have partnered with them to be able to offer Family Connects and Healthy Families at the same time. Our shared vision is that Family Connects is a gateway into other home visiting programs. Getting that alignment in play and in practice has taken some adjustments to be able to do that. And so I think the next slide talks about some of the, as a council, and Kate's already talked about it, being able to assist with how do those policies align up, and then also giving us locally permission, if you will, to adjust and flex to be able to meet the community partner and community relationships. And then also in terms of the council's support, I would also to advocate for the Senate Bill 1555. I'm pleased, super pleased that that is going through the legislature and seems to be all but done, knock on wood. And that will really help us as we are expanding this out further. And then the other piece, and it really is related to the alignment, is from the council perspective, as we are implementing these community-based programs, being able to think about and help allow that connection to how things work at the local level as well. And I think hubs play a critical role in being able to be that translator between the state level and the local level. In thinking about this, public health has a real community approach to things, whereas programmatic enter things at one family at a time. And so being able to be that translator between individual and systems approaches, I think is really key. And so as a council, being able to think through, like, how does that translate into our local level? So with that, I will happy to answer any question. And I do have our data in terms of the race and ethnicity, if that is of interest to the group. Just quickly, we have out of the 35, we have 16 Spanish-speaking families and 28 of the 35 identify as Latino Hispanic, which really does mirror our population. And I could go deeper with that, but.
Okay, thank you, Lisa. And I apologize for needing to rush you through that. Council, obviously there are lots of pieces of all of these presentations that we can pick up on, and hopefully we'll have time to do that after our break, when we do some of the council updating among ourselves. So while you're eating lunch, give a little bit of thought of how you'd like to frame up what we've heard this morning as far as next steps for the council and our support. So Kate, Steph, Sarah, all of the staff who support you in this, and Lisa from the Hub, thank you very, very much. I'm confident we all have learned a lot. And actually, you're just full of good news, which obviously is is sort of a welcome relief from parts of the rest of our lives. So thanks for the good news and the great work that you all are doing to support kids and families. We're fortunate and honored to be a partner with you. So thanks. And council, we are a few minutes late, but let's still reconvene at 12:30 if you don't mind. Okay, thanks everybody.
Sue, I have a quick question for you. Oh, she may have left. Or Remy, if you're on.
Hey, Kate, I'm on.
Hi, great. Our agency director supposed to come back at 12:30 since I'm playing that.
Oh, no.
Okay.
Yeah, we're doing a little ELD legislative update, and then we're going to do some council member roundtable updates. So
awesome. So I will sign off.
Thank you, Kate.
Take care.
Bye.
Bye.
Sue, I just wanted you to know that I'm back. I'm just eating lunch, so I'll turn my camera on shortly.
Okay, no problem, Angie. Thank you. I know it's always a short break that we have.
This is Ann. Same with me. I'm here.
Okay, thanks, Ann. And Cully, I know you need to jump off at some point for legislative stuff, and 'tis the season. So it looks like many of us, most of us are back. And we've got a lot to do in the next hour and a half. So let's continue with our meeting. And there was no public testimony submitted, and nobody has asked to address the council. So we will move on to legislative updates from ELD and agency partners. So Alyssa, welcome. It's nice to see you. And I see we have Troy on here as well.
Yes, thank you. Troy is going to, I think, lead us through really the bulk of what's been happening this February session. And I'll kind of close out with just some considerations for the council going forward.
Okay. Hi, Troy. I understand you've had a lot of spare time on your hands lately.
So much time.
So much time. Don't know what to do with it all.
I wish I had scheduled a vacation midway.
Yeah, I talked to Alyssa about that one. Council members, just so you know, Troy has been incredibly busy, both he and Alyssa, but every time I talk to them, they're just back from or going to another legislative meeting, hearing, whatever. So thanks for the work that you're doing 24/7.
Yes, thank you, Sue. And I had a slide to sort of keep me on track because there's a lot going on. So it looks like Remy's sharing that now. And again, for those who don't remember me, either on this call or in the public, I'm Troy Duker, the Government Affairs Manager for the Early Learning Division. We've had quite a busy sort of policy and budget ask season for the division. And here's the list of pieces of legislation in the budget asks that I'll go through with a brief description and then a status update on where they are in the process. Fortunately, we have only 12 days left. That means we need to get these last pieces moving as soon as possible before the end of session, but it feels good to be wrapping this up, to be quite honest. The first bill, House Bill 4032, this was a bill that had been worked on by Rep. Power in the Early Childhood Committee. What this piece of legislation called for was that the division put together an information resource on the rights and responsibility, on the rights of children experiencing disabilities. So that's the IDEA Act, the Americans with Disabilities Act, and the information associated with public accommodations and reasonable accommodations for access to public accommodations. And then the bill also called for the division to require training for early care and education staff, on the rights and resources for children experiencing disabilities. This was passed out of the House Early Childhood Committee a couple weeks back, and now is sitting with the Joint Ways and Means Committee. I haven't seen a sub-referral to a subcommittee yet, so it's not clear that this bill is going to move, as there's a fiscal attached for the work for developing the information resource as well as the training. So yeah, it's not clear this is going to move out this session. House Bill 4033 ginned up a little more controversy than I was hoping for this session. This goes back to work in the 2021 session with House Bill 2055, which created the Tribal Early Learning Hub. That hub is separate and distinct from the 16 regional hubs that we're all familiar with. And so as a part of the process for developing the purpose, function, and administration for the Tribal Hub, in last year's legislation, there was a Tribal Advisory Committee that was set up. And we met with the tribes after the bill passed, and they had raised some issues around the government-to-government relationship and had asked whether that government to government relationship was reflected in the membership on the Tribal Advisory Committee. And the main points of, or the two central parts that were at question was the parent group that was a part of this advisory committee, as well as a voting member from a statewide tribal organization. And so because the effort here is to recognize tribal sovereignty and to work together on what ongoing policy for early career and education looks like within the boundaries of the tribal nations. Since we're working on that together, we wanted to elevate concerns regarding tribal sovereignty and ensure that the government to government relationship is actually reflected in the composition of the advisory committee. So 4033, after all that being said, removed the advisory committee and reduced one member to a non-voting member on the advisory committee. And again, that's because parents don't represent tribal policymaking. And they don't represent tribal governments. So that's not reflective of a government to government relationship, which we're hoping to foster on the advisory committee. So this did pass out of the Senate Education Committee. You can see it's a House bill, so it's already made it through that chamber. And it passed out of the Senate Education Committee yesterday, and it'll be on the floor tomorrow. So I'm hoping that since it's been scheduled, that means they have the votes and that it'll move through with no issue. House Bill 4005, Rep. Power has called this the Child Care Roadmap Bill. I've termed it the Omnibus Bill because there's a lot going on in it, including the delay of the establishment date for the Department of Early Learning and Care from January 1, 2023 to July 1, 2023. It also includes the transfer of the employment-related daycare license-exempt childcare provider background checks from the background check unit at ODHS over to the Office of Child Care at the Early Learning Division. And of course, that background check process for us is what we call the Central Background Registry. So this bill would require the enrollment of those folks within the Central Background Registry. There's also the increase in reimbursement rates, which you may have heard about in regards or in relationship to the $100 million Child Care for Oregon Coalition package. The change, the increase in rates is found in this bill, but that'll be paid for out of the omnibus budget bill that comes out at the end of session. This bill will be up for a work session by the full Ways and Means Committee tonight at 5:30, which is a good sign. So if it makes it out of the full Ways and Means Committee, it'll be referred to the House floor and then over to the Senate floor, and then hopefully over to the governor for her signature. 1512, this was not a bill that was worked on by the division. It actually came from, it was a Judiciary Committee bill in the Senate. And this would have made some changes to the way that we make determinations for enrollment in the Central Background Registry, meaning we would have to take into account moral character and fitness of a person in relation to whatever criminal convictions they may have to help determine whether they were suitable for enrollment. And this came into direct conflict with federal statutes around automatically disqualifying crimes for enrollment in the Central Background Registry. So we were successfully carved out of that portion of the bill. There's some lingering work here. I've followed up with Senator Dembro. It's not clear whether this bill is going to move. I saw that it had a subsequent referral this morning over to the House or the Senate Rules Committee, which means there's still some work that needs to be done to the language and that they need it to be in a committee that doesn't have deadlines for moving legislation. So it sounds like they're still leaving the door open on this, making it out, but it's not crystal clear to me where they are on that process. Hopefully I can get more information from Senator Dembro here shortly. Senate Bill 1547. You may remember this policy change, or at least proposed policy change from last session. This bill came out of a recommendation from the 2020 Child Care Background Check Process audit that examined the background check process at the Department of Human Services, the Early Learning Division, and particularly the Office of Child Care, as well as the Oregon State Police. And one of the findings was that recorded programs do not have the same background check standards as licensed programs, and there's a sort of gap in oversight for these types of programs. We don't know what kinds of background checks these programs are performing, what the criteria are for those background checks, nor do we know how often those checks are completed. So the audit recommended that we introduce legislation to create a new set of subject individuals for enrollment in the Central Background Registry, and those are the staff and volunteers of the recorded program. So they'll have to, if this legislation makes it through, go through the enrollment process for the Central Background Registry. I'm going to try to keep this presentation brief because at 1 o'clock, this bill is going to be up for a work session in the Joint Ways and Means Sub-Education Committee. And hopefully I don't have to speak, but I just want to be there just in case there's any questions. Senate Bill 1591, this was introduced by Senator Rachel Armitage from Senate District 16. You may recall her predecessor, Betsy Johnson, retired to run for governor. So she was appointed to that seat and had very little time to sort of come up with a bill. So I think with 9 days before the start of the legislature, she introduced Senate Bill 1591, which changed our certified family max group from 16 to 20 for 2 years. We had some significant issues regarding moving away from even further out from current recommendations for national best practice standards for large family homes, as well as some issues with the 2-year sunset because of the amount of work it would take into actually changing the rules for certified family providers, only to have that drop off 2 years after the bill's passage. That bill, we did request opposition for that bill, and we were granted the ability to oppose it. It's not often that we oppose legislation as an agency, but this was significant enough that we had to sort of stop this for going forward in this short session. We will, Senator Armitage will not, it's not clear that she's going to run for that seat. I don't think she is going to run for that seat in the general election, but we're happy to continue conversations like this. We're not closing the door on this sort of conversation. We just didn't think the short session was the appropriate space to muddle over such an important piece of policy work for childcare. The next few items are budget asks. We'll start with preschool program expansion and the suspension, expulsion, prevention program. You all will recall from last session that the legislature did approve funds for preschool expansion as well as the suspension and expulsion prevention program, but that the majority of funds for both programs were held back, meaning, or the term is called unscheduled, is a term used for holding funds back that have already been allocated. And fortunately, because of our great program staff at the division and Alyssa and the presentations before in the Joint Ways and Means Sub-Education Committee, those funds will be released so we can move forward with expanding preschool programs as well as establishing the suspension and expulsion prevention program. And then the positions requests, so there's the two requests, the 34 and the SPA, the special purpose appropriation, which was granted to us last session, sort of very similar to having funds unscheduled. That money's already been set aside for those positions, but we had to come back with a plan for the release of those funds. And then we made a request for another 40 positions at the start of the biennium, and then in conversations with LFO, we reduced that number to 35, with the request being to have the funds for the 35 positions begin at the end of session to the end of the biennium, but we're going to still make the request for those 5 other positions in the 23-25 biennium. Anyway, to get to the point, we've had a presentation before the Joint Subcommittee on Education on these positions, and this is sort of sitting with a lot of other budget requests that don't have homes and bills with the Joint Ways and Means Committee. And so hopefully this will move, but unlike a bill, there's no way to track it in a process. Similarly, for the $100 million child care package, You all may recall that the Child Care for Oregon Coalition initially made this request. This has been brought onto the governor's agenda as well as the House and Senate agenda as well. So it looks like this has a lot of momentum for moving. Again, the $100 million included our $4 million ask for positions, the 35 positions that I was just mentioning for DALT, as well as wage enhancements for childcare staff, and tens of millions of dollars in grants for childcare supply building and capacity building work. Again, this is sitting with Ways and Means, and hopefully we'll hear shortly what the status of these is. That's all I have. I don't know if you typically take questions after. Because surprisingly, I think this is my first ledge update, even though I've been with the division for a couple of years.
Yeah. Well, nice update. Yes, Peter.
Troy, House Bill 4005, did it have opposition to it at all? Or was it passed unanimously out of the sub? Do you remember?
I do not recall, honestly, whether it had unanimous support in the subcommittee. It was Monday. I don't remember what the vote was.
I don't think it was unanimous. I believe we got a courtesy yes from Rep. Levy, but I think we got 2 no's from the Republican members.
That sounds right. I think it might have been Thompson and Levy.
Yeah.
Yeah. Okay.
Okay. Well, good luck to it. I hope it can go through the full.
And that's pretty consistent with what we've seen with even just the reports on program expansion, as it's sort of been acknowledging receipt of report has also been kind of falling along party lines, but moving forward.
Okay, thank you.
Yeah.
So Troy, I don't remember, is the $38 million that's going to be released, is that part of the 100 million or not?
No, that's a part of the 68 million from last session that we received in preschool expansion. Former Rep. Buckley can probably explain this process better than I can. But there are funds that are unscheduled that DAS holds back from being released to an agency. And so now we're just in the process of getting those funds. I've heard the term rescheduled and I've heard the term scheduled. Anyway, they're going to give us the other $38 million at the end of the day.
And is that coming through 405 or it's just a Christmas tree bill?
It's not attached to any piece of legislation.
Oh, but
so really the money had our name on it from last session. We just had to come back and have it released to us. So it's not a new funding request. We got the funds in the 21 session. We couldn't access them yet.
So I'm just wondering, can we now, are they ours now? They've done what they need to do so that we can access them.
Yep, correct.
Yeah, we'll still need, when we're actually ready to award, grant agreements, DAS will schedule it, but we don't have to get any more kind of permission to be able to access the resources.
So, great work. I mean, Council, I'm sure you know what staff did is they sent out a survey to the entire childcare world saying how many more slots, childcare and early learning world, how many more slots could you use and fill if the legislature released this money, and got a great response. So nice outreach.
Yeah, definitely. If folks, have a couple hours to kill or while you're driving around, want to listen to the presentations. But I think both with program expansion and suspension expulsion prevention, just really thorough data and information that I think was really appreciated by the legislature. And I think is just a really important peek into the complexities of doing this work and doing this work well and with intentionality. I think going forward, even this process and the questions that the legislature raised last session around, kind of community readiness, facilities availability, we're kind of reaching that critical tipping point where conversations I think are starting to shift, and we need to start talking about capital investments, and we need to start talking about how we're looking at wages across all of our programs. Right now, wage parity is only folded into preschool promise and OPK. And it also is at a point in time. And we know every year, every 2 years, local districts, they bargain, you set new wage requirements. And so how do we also think about setting an expectation and revising our funding formulas to be able to keep pace with K-12? I think also looking at how we support school-based preschool programs to not just utilize classified staff, but utilize teachers with BAs, how to support increased pathways, which is a lot of work that John's team is also doing. And we have the resources in the Student Success Act that have gotten a little bit stalled with COVID, but a lot of dedicated resources to address workforce and access to higher education. But I think there's going to be a lot of opportunity as we're going through the 23-25 prep for that budget to think about what's the next phase of work within our existing capacity. Because I think that's going to be the challenge we have to balance is we are building a new agency and a suspension expulsion prevention program and continuing to expand slots and building a professional learning system and continuing to overhaul licensing. And so where can we fit in new bodies of work, or where are there opportunities to make improvements to the bodies of work that we're already implementing? And I think this short session has been so crazy, as Troy has demonstrated, with just the number of bills that are impacting us. And I'm hopeful that this is just the beginning, and we continue to see this emphasis and this focus and interest in childcare and early learning going forward. There's a lot of opportunity with that. And I think it's important that we all have a really clear vision of where we want to go.
Yeah. Any other questions of Troy before he runs to yet another hearing? Okay, Troy, thank you. And Troy does a great job of those, Q&As with the committees, and somehow he pulls off the answers. So I'm always very impressed, Troy. You represent us and kids and families really well. So thanks for your work.
I appreciate that, Sue. And I'll see you folks next time.
Okay.
Bye now.
So Council, the other legislative update that we received, basically Colt sent me an email and said, Alyssa and Troy's update will be what stands for ODE as well. And then I sent you all last night the ODHS legislative update that I just forwarded the email to you that I received late yesterday from ODHS. But really very exciting improvements and expansions in their work that will influence services for children and families. They have their local equity infrastructure. And once again, it's going back to the theme we heard from OHA about the community-based, community-focused, parent voice, et cetera. So I really do hope we can spend a little bit of time this afternoon still talking about our role in that. ODHS is talking about community engagement. They're wanting to add 12 positions for that. They want to add 40 positions for the building local equity infrastructure that was in the information they sent us. Child welfare staffing, they're trying to increase significantly. And then the changes to TANF that they're proposing, $27 million of enhanced services for TANF families. And if you read that, it's very exciting because there has been a resource limit for TANF families for eligibility of $2,500. During COVID, they increased it to $10,000, and now their proposal is to have $10,000 be permanent. So once again, these are all the wraparound services that our families desperately need. So ODHS is certainly targeting that as well. And I think we can celebrate what they're doing. If you really want to hear about TANF and the changes they're proposing there, just listen to the Joint Ways and Means Human Services Subcommittee meeting from February 9th. And Liesl and Claire and their staff did a great job talking about TANF improvements. So those are the legislative updates. Any questions? Yes, or comments, Kali?
I just have a comment. I think that the resource, particularly the 100 million childcare package is a significant step in the right direction. On the ELD things, it's Alyssa, this is not, I think this is beyond sort of what you have control over, but we have a huge issue with procurement. I know it's come up before. Dollars are not getting to communities. They're not getting to the hubs in the way that they need to. The hubs aren't able to get them out to providers. So on one hand, we're getting this resource to expand slots. And on the other, because of the system, whether it's the legal side or the finance side, like money's not getting there. There are huge delays and we're hearing about it on the ground. So I don't know what we as a council can do about it, but it's alarming enough that I felt like I should bring it up. And Chair Miller, if there is something we as a council can do to address this issue, I'd like for us to do it.
Kelly, absolutely. And we've heard this similar offers from legislators too. I think I just found out yesterday that it sounds like there's going to be at least one staff person leaving ODE and some internal changes. It's going to create another kind of lack of capacity. We're hiring, I believe, 3 procurement specialists over the next couple months that we requested through the 2 different packages, as well as our own procurement director. So starting to build that capacity ourselves will help so that it's not us kind of competing with all of the ODE procurements. That being said, I believe the procurement director said there were 10,000 grants just in the tier 1 procurements that all of the offices in ODE identified. So just to give a sense of scale, I think there's kind of a bigger enterprise conversation about procurement. I think the other challenge is the legislature, they have continued to adopt more and more laws that just end up adding more kind of barriers or restrictions or processes to procurement. And so there's also an element of, you only have so much flexibility within the procurement laws for the state. And that's, I think, the bigger conversation that I think I don't have all the insights and expertise on, and where there might be opportunities to winnow those down or be more strategic about them. But my understanding is every agency is struggling with procurement. And this is a sector that's also been particularly hard hit by the Great Resignation. And so we already were kind of stealing each other's procurement people. And now that's becoming even more difficult because you do need understandings of state procurement systems, but then recruiting externally is a challenge for everybody right now as well. So it is compounding, but we're hopeful that by building our own shop that really understands and knows the business of ELD and DELC will help us kind of streamline. On the program expansion front, we've been actively working with procurement so that we can get these requests for applications released. And this time was the first time we did a request for information for OPK, which is something we never knew we could do. It's a much simpler procurement process when you're only giving dollars to existing grantees. So I'm hopeful we can find more of those streamlined approaches and only focus our kind of more complex procurement strategies on those competitive structures like new program expansions going forward. But definitely share your concern, Kali, and we're hearing it too. There's definitely some grants and contracts that are well overdue.
Yeah, excellent question, Kali. I mean, have the hubs gotten their money yet? Do you know, Alyssa?
No, I believe grant agreement should have been executed in October. We prioritized direct service grants and those that should have been executed in July. So they are being worked on. And I could follow up with kind of the projected timeline to execute those.
Okay.
Yeah, and what I hear is the places outside of actually where I sit in Multnomah County, they don't have anything to backfill the dollars. So it's a big issue.
Right.
Yeah, and programs are reaching out to us directly. So any program that's kind of at risk of closure, losing funding, having to lay staff off, we've intervened and worked with ODE to prioritize. So we've prioritized direct services over infrastructure investments, and that's kind of been our initial approach. And then since then, we've had some programs that didn't fall into that category or were later than a July execution that have told us we can't make it past a certain date, and we've been able to turn those around, but it means something else doesn't happen, right? So we're trying to be really thoughtful about those, but feel free, Kali, if you know of any programs, I'd be happy to talk more. We don't want to see any service delivery being interrupted.
Okay, thanks, Alyssa. And the other update I asked Alyssa to provide, because several council members have asked me about it, is on the suspension expulsion program. And we don't have a lot of time, Alyssa, but if you could just give the council a quick update on where that is and what the timeline is for that, we would appreciate it.
Yeah, and I think John is actually going to join in our rulemaking preview too, but we did.
Oh, we can do it.
Yeah,
then
so he'll have a lot.
Wait.
Yeah, he'll have better info than I will for you on that.
Oh, okay, great.
Yep.
We'll do that at 1:30 then. Okay, thanks, Alyssa.
Yeah.
Okay, if there are no other legislative questions from council members, let's move then to the part of our agenda where we all get to share what's going on in our worlds, and especially, you know, where can the council fit into and support what's going on. And Kali, I know, is going to have to leave shortly for a legislative meeting, so I just asked if she would just lead us off with this before she has to go.
Sure. So one thing I wanted to bring to the council, there has been over the last couple of years a conversation between education and health providers that has been focused on how do we sort of bridge the two communities. And the education representatives have been largely superintendents, mostly in the Tri-County region, Washington, Multnomah, and Clackamas County. That has expanded recently. And then healthcare providers like Care Oregon, sort of, I want to say, Health Share, so the Cco providers. And I don't know if you recall, but last year I sent forward a white paper that was focused on that connection between health and education and the idea of how do you create these ecosystems through a pilot approach. Peter Buckley has been at the conversations over the last year as well, and some other community leaders. And there's a real interest in really, I think beyond creating new pilots, I personally think we have a lot of pilots looking at what is happening in communities and ecosystems that are working, that are coordinated and connecting education, early childhood, and health to lead for change. And so I think as we think about where these places should be, I just wanted this to be on the council's radar. I think we know a lot about what's working. Early childhood is definitely an emphasis in this, and the connection between early childhood and the K-5 schools. And so as this group thinks about where should resource be focused, where should attention be focused, this feels like something that the council should be aware of and maybe provide input on. So and I don't know, Peter, I didn't give you a heads up about this, but if there's anything that you want to add, since you're part of that committee.
You bet. Well, actually, it's a good lead-in because I was going to do a little bit of a brief on that. Because we are moving forward in Jackson Josephine with a planning process to actually try to develop what that white paper called for, the child success delivery system. And it's going to be a 10-month planning process that hopefully at the end we will have a blueprint and a proposed 5-year budget for what it would look like to actually do this work in a fully comprehensive, inclusive manner. So it's pretty exciting work. We're going to be working with Co-Creative, which is a consultancy group that the Ford Family Foundation, through Ann, introduced us to several years back, and we found to be very effective in moving collaborations forward. So they're going to be facilitating the process with us. But I do think this is a direction all of us are moving in. I was interested to see in the OHA's presentation this morning talking about the community investment collaborations. It's like, those are happening. They're happening. There's one in Douglas County. There's one in Coos and Curry. You know, we have these collaborations that are in development. My hope is that this the roundtables work can just kind of get a framework that could be consistent for people to work within and push forward in awareness and accelerate the work. So that's my hope for it.
Yeah, and my hope, I think, is to align and connect dots so there's not all these disparate pieces. We've heard DHS, while their work is more internally focused, they're also looking at things such as this. And so I really want to just be aware of what the larger universe is doing and help people focus on, you know, things that are working, and then seeing how we can scale and replicate. It's not, when I say replicate, what's happening in Medford is not going to look like what is happening, say, in the Dalles, but there are components, and certainly CI has done a lot of work in different communities, and we have seen like ingredients to success. And so how do we replicate those and support those throughout our state? So that's a big thing that's on my mind. I think also with the childcare, the passage of the childcare bill, I think there is a role for the council in helping communities understand what that means for them. I had a chance to talk with Representative Power about this bill, and she's looking at you know, the role that she can play as a legislator to inform communities about the opportunity. I see this as a big deal because we need more, as Alyssa articulated, we need more resource in the system to truly change the narrative, not just expanding spots, but really addressing the workforce issues. It requires investment. And right now we do not have anything committed from the federal government, though I think, you know, we're still hoping something happens. But in talking with legislators, I've learned that we don't even have the capacity to manage. If there was a huge infusion, we don't have the staff to manage it at the state level. This is our first opportunity. And so I think not only helping people understand the value add of this 100 million, but being able to tell the story about what is happening once, you know, over time. And I would love maybe 6 months from now to invite people to share the impact that it's had on them to the council, because I think we have to capture what it is, why it's important, so that more of our community around Oregon sees that this is critical for our children and for our state to thrive. So that's not very specific to my region, but it's where those are two areas where I'm spending a lot of time, Chair Miller. So that's what I chose to share.
Yeah, no, that's great. And I appreciate it. And I appreciate the work that CI has done in helping pull all the coalitions together to get the $100 million ask even in front of the legislature and to advocate for it. So nice work, great work. And, you know, it's interesting because it kind of rolls back to this bigger conversation we had this morning about communications, right? And once again, especially Alyssa, I know you aren't flush with staff looking for new projects, but certainly your comms director and your comms staff, we should at some point, I think it'd be helpful to have a conversation with them about how they and we can work together to improve the outreach.
Absolutely, absolutely. And we should be hiring our communications and outreach director in the coming weeks. We've kind of in the last stages of that process. So we're really excited to have still not a huge comms team, but have at least one more key player on the team to really help us craft our external strategy going forward.
Great. So maybe one of our future, one sec, Kelly, in like April or May, Alyssa, maybe we can have whoever the comms team is join us, and we could just hear from them and give them some ideas too.
Yeah, absolutely.
Remy will capture that, I'm sure. Yeah, Kali.
I forgot one quick thing. We have a facilities brief that our policy team has been working out that's supposed to get released either the end of this week or beginning of next. So I would love to share it with the council. And there was an ask in this legislative session for, I think, 10 million for more resource to expand facilities, because what we're finding is there's actually not enough places to have childcare. So, but this policy brief does gives you insight into what's happening with facilities statewide. So be on the lookout for that from CI.
Great. Thank you. We'd love to see that. And why don't you just send the white paper again to the Health and Education one, Kali, if you would do that. And Council, just to draw your attention in the chat, Katie had to leave for a legislative meeting, but she gave her update, which, as you know, is focused on childcare and the fact that they've gotten millions of dollars. Some of it was legislative directive ARPA funds to really expand childcare in Central Oregon, with OSU Cascades as a huge partner in constructing mobile classrooms, speaking of facilities. And labor workforce, every time I talk to Katie, that's on the top of the list as far as challenges and barriers to increasing childcare. Okay, other updates from council members of concerns, focuses. We have lots of sectors and regions represented, so please let us know what's going on.
All volunteer.
Great, Angie.
So most of you know that I run the early childhood programs for the Confederated Tribes of Grand Ronde. And so what I'm running into right now is just the disparities, not disparities, the differences between COVID protocols, between our programs in early childhood and K-12 programming, and just trying to keep up with communicating with parents about what our restrictions are, what our quarantine periods are, all these different things. And we are a Head Start grantee, so we are also now required to have all children 2 and above wear masks. And so I can see my parents just get confused really easily because they have older children going to public school. They don't have to quarantine after this exposure, or they don't have to, wear a mask coming up. I mean, they do right now, but I can see as the mask mandate goes away, ours will not. So we're just continually keep trying to communicate how we're regulated by different bodies and how we're going to have to continue to do some of these things. We were recently closed for 3 weeks because of the Omicron wave, and my parents have been extremely patient and understanding. But this has been so hard on all those families that, parents are trying to get back to work, or their employers are requiring them to get back to work. And it's just been really hard to close classrooms because of exposures and quarantines and people not having backup childcare. There is no other place out here besides us. We're it. So if their child isn't coming to their preschool, their parents are having to stay home from work. So those are some of the things that we're juggling. But on a different front, we are working on expansion of infant toddler care in our community. I started an infant toddler classroom this last year. We're hoping to expand that next year to 2 classrooms. We're converting some of our home-based slots into center-based slots for those 0 to 3. We'll continue to have our home-based slots, but just more of the center-based 0 to 3 slots. There's some growing pains and learning curves to go along with that, trying to transition kids out of that 0 to 3 program into our pre-K programs as they turn 3 years old. And we're not used to transitioning kids and moving them mid-year. So it's one of the things that our teachers and parents are getting accustomed to. Then just finally, on the tribal hub, I just want to say I'm very hopeful about the fix passing regarding the tribal advisory committee. And it has really got me thinking about the parent engagement piece. And although we have a policy council, I'm just really trying to think hard about new strategies to get engagement from parents, to get feedback from parents, and get outside of the box. They're not going to come to meetings. It's not a meeting, but just different avenues of communication that are open, and also a little bit of prompting. Just really open-ended general questions don't always get them, thinking about what they might they think of us as a school, for one thing, which we are. So they don't really think that we're going to be supporting them in other aspects of, their lives, like connecting them to other resources. And I do believe it's extremely important to have that community voice to guide the direction of our program. And just earlier we were talking about these the community voice in the Oregon Health Authority updates, and it just really got me thinking about moving outside of the box and finding new ways to gather that input from people, but it's not a meeting. I think that's everything from my area at this time. Thank you, Chair Miller.
Okay, thank you, Angie. You are a frontline worker if there ever were one. And I don't know, Alyssa, if you have any magic wand on aligning COVID regulations, or, it is confusing.
It is. And the Oregon Health Authority is kind of that connector, right? And the senior health advisors, and we're trying to align with K-12 where we can, and we're getting closer, but we still have major differences because we don't have a vaccination requirement or a mask requirement, and we don't have access to vaccines for children. And so it creates important nuances, but we're continuing to review and keep an eye on the CDC, but also watch our Oregon data trends. And our senior health advisor, who's a pediatrician, is very eager to find ways to relieve the pressures this is creating for programs, but also for families, while we can keep kids safe. My magic wand would be spent not on COVID guidance, but just no COVID.
Yes, but there are several people on this call who would agree with that.
I'll second that.
Yeah. Oh my goodness. Other updates from council members?
Well, since we're talking about COVID, I'll go ahead and go. The bad news is that the CDC or the drug companies, I guess, rescinded their proposal to approve the vaccine for the younger kids. And for good reason. Number one, we want to be sure it's safe. And number two, we want to be sure that we're sending the right message. I think because a third dose might be indicated for those kids. And we've done enough, I think, during COVID of giving mixed messages to people that confuses people so they think that maybe we don't know what we're talking about. So I think it puts parents of young kids less than 5 in a tough bind, because everybody else is really loosening and returning to normal, and they are not. If they really want to keep their kids safe, they're still being pretty restrictive with their activities. So, I think all those things are beyond our control, but I think we just have to give people some grace and some understanding in what they're going through. The good news is that COVID is really going down throughout our hospitals. Everybody knows that. And the community penetration is much, much less. I think everybody in healthcare is not, we're sort of cautiously optimistic, but we had our hopes up before, and then we got dashed by a couple of other variants. So I think people are being very cautious about that. And as far as children are concerned, certainly we saw a lot more kids getting COVID, young kids as well as school-age children. Unfortunately, the vaccine has not been embraced by school-age children in very large numbers. I think the last I read was like 38% of kids were vaccinated from 5 to 12. Hopefully we will have a little higher numbers once we get younger kids okayed for that. But what the children's hospitals now, I think, are seeing a little bit more breathing room. They were really full for a while, which was different than all of COVID, but they're sort of gearing up for an onslaught of what's called MISC, this multisystem inflammatory disease of children that tends to follow COVID. It's pretty rare, but it can be pretty serious. And just because of the sheer numbers of children that have had COVID, they're concerned that they might see higher numbers of that. On little happier notes, in Yamhill County, we've got with some of the federal money, we're trying to maybe do some combination housing that has childcare embedded in it. And I think that's still kind of in the planning stages, but it sounds hopeful at least. And lastly, when we were talking about the home visiting program and the workforce problem, that really hit home because we have such trouble getting nurses, and particularly in rural hospitals, that I wonder if there couldn't be, and particularly where volumes of births in areas are low, if there could be some partnership with those same RNs that are working in birthing centers who already have a little relationship with the mothers that are perhaps given birth in their area to be those home visiting nurses, because it is kind of a spotty thing. And that might be a way to kind of double up that workforce. That's about all I've got.
Okay, thanks. And thanks for the insights on COVID and interesting option on, doubling up and how we really take advantage in a positive way of any capacity that there might be in any nursing programs. Would be great. George, I'm going to put you on the spot. The only thing I've heard about Eastern Oregon lately was the 100-car pileup on I-84, which you weren't a part of, thank goodness. But how are things in education these days, K-12?
Thanks, Sue. And I'm glad that I'm okay. And I felt bad for a lot of travelers as well, and families and truck drivers. And my understanding is that the area hospitals were very busy for a day and a half due to that.
They were.
Yeah. So I would just say, if as it relates to school and Omicron and the variant, for us, it's gone down significantly. We were impacted for, really once we came back from January, we had 180 cases right away, then in a 1 week period, and then around 220 cases the next week. And then just last week we had 26.
Wow.
So we went through a big surge, and then we came down from that surge relatively fast as well. And I think that's kind of similar to a lot of other regions in the state and nationally. Then the masking as to be optional, or the mask mandate to be gone by March 31st is something that was welcome news when we first heard it here in this region. And then within a couple days, we had a lot of people upset still because they just felt it should be, why March 31st? Why not March 1st? Or why not February 28th? Why not March 18th? It just became a lot of people, why are we picking the date? So basically the concept for me is that there's a lot of lack of trust in government, lack of trust in health industry, or lack of trust in education as well. So there's a lot of people that wind up talking to me, and they believe that they know more than doctors do, or they believe that they're lawyers now, and they have the rules for how we should be operating. And it's I think it goes back to that concept of where I was saying there's a lot of disillusionment. There's a lot of disillusionment. I'd say, especially where I'm at, where folks just want to start going forward with their day-to-day lives. So what I'm doing about that, of course, is I'm doing some advocacy and telling the state it would be nice if we could move forward sooner than March 31st. There's definitely some regions that I believe are ready to move forward sooner than March 31st. Even if I tell you right now, we had 26 cases, and that's not having positive cases. That's just having events where somebody had a symptom, or somebody had is a part of a close contact and they have to isolate and quarantine, or else they do have COVID. And I think we had 5 cases of COVID total. You know, the folks are basically, why are we waiting? If our data is low, if we're ready to operate, why are we waiting? So that's a thought process that people have. So I'm you know, advocating to the state that if there are regions that are ready, it would be nice if they were given that opportunity to move forward. I'm also advocating. It's very hard to say there's not a vaccine requirement for students or for parents or for others, but we're going to make a vaccine requirement for staff, and it creates kind of a staff viewpoint of us against them, or in group, out group, and it creates it hurts morale with staff members for them to have different requirements than others. So if we're going to lose the mask mandate, then we should really, and if masking is an option to wear it or to not wear it, then it just needs to be that. And we can't have one group having one set of rules and another group not having any rules. So those are things that you know, are taking place, and people are positioning their viewpoints on that. Also, if you're going to take away mask mandates, it's just harder to do quarantines based on that. So then you have to do a lot of contact tracing. And if the goal is to keep kids in school every day, then instead you're spending your time contact tracing and then putting folks in quarantine, and the goal is to keep them every day, it doesn't work. So there's a lot of folks going back and forth with, let's make rules that are simple. Let's make sure they're easy to follow. Let's make sure that if you're going to let go of the mask mandate, then make everything else also recommended, or you know, but not required. So I'm just going to say there's a lot of things running their course with how people are looking at systems and challenging those systems, and because they're tired, and that's that. So
right.
And I would even say the same thing with the, you know, early learning versus K-12, that you do see that. You see early learning people saying, hey, we've got these rules and you have these rules. And that doesn't, you know, they question it because of that as well. And then it makes them feel like their child should be given this experience versus their child that's getting that experience. So I would just say we're in an interesting time. And I hope that we can get through this kind of recovery period and get on to the next thing sooner. There you go.
There you go. I think we'll all second that. Any other comments from council members?
Sure, I can jump in. I think I wanted to share with you that over the course of 2021, we at the Ford Family Foundation, we underwent a strategic planning process to think about what our focuses are going to be for the next 10 years. And I just wanted to share them with the folks here, because it's not a huge change from where we've been, but it's a real commitment to ensuring that rural children have the family, educational, and community supports they need to thrive. And a big part of that focuses on young children, not all of it. I would say about 20% of our funding for the foreseeable future really focuses specifically on young children. So that would be, you know, our budget next year will be 55 million. So it'll be, you know, 10, 11, 12, $13 million focused specifically on young children. And I just wanted to share with you what sort of the specific categories of work have been and are likely to continue to be, but in a sort of clearer way. So the one is building strong systems of family caregiver supports. And we've been doing this for a long time. We've worked for 20 years on parenting education. And so we started that in the early 2000s, and the Oregon Community Foundation joined with us in about 2010. And since then, with the philanthropic funding, there are parenting education hubs in 35 out of the 36 counties. And now the state is putting money into it, which is so exciting that we're finally gotten to a point. I think it's just a perfect example of kind of philanthropic and public sector collaboration where we can help build some of the infrastructure, sort of do some proof points and piloting and so on, so that there's something, then there's some investable infrastructure, if you will, for some of the big public dollars. So that's pretty exciting. We've done a fair amount of work on home visiting. And with regard to what we heard about this morning, our work has really focused a lot in our home county, which is Douglas County, and Coos County, which is we also consider kind of a home county. And what we've been investing in is sort of system coordination among home visitors. We're not paying for slots, but we are trying to make sure that, again, the infrastructure is working well so that the home visitors are in touch with each other, collaborating, learning together, forming learning communities, able to refer from one home visiting place to another if your slots are full, or if another home visiting approach is more relevant for the kids and families. And then in addition, I think a third thing in that whole area that it crosses over with what we talked about this morning is the early childhood mental health systems and workforce. And again, we have a particular focus on our home county, but we've been working on a system of care. We've been hosting a system of care coordination in Douglas County that really focuses on health complexity, bringing in OPIP data about health complexity in Douglas County, getting all of the behavioral health providers and health complexity related providers in Douglas County to be much more coordinated. And it's already had sort of impact that we can see down the road. So that's one big chunk of our work. A second big chunk of our work is child abuse prevention intervention, really focusing on adverse early childhood experiences, doing a lot of child abuse prevention, funding, CASA, child advocacy centers, et cetera, across the state. We have a large program on child sexual abuse prevention called Protect Our Children that has already trained 30,000 people across rural Oregon in child sexual prevention, understanding it and what to do about it. So that's a second big chunk of our work. And a third big chunk of our work is on sort of increasing the quality and quantity of early childhood programs, which really focuses on childcare, P3 alignment, again, quality improvement in workforce, early literacy programs, and so on. And so I think there's a lot of overlap between what we're doing and what the council is doing and what we've heard about today. And I think it's what we're always looking for is that right sort of partnership between philanthropy and public sector funding. And I think the examples that we've now had after 20 years of investment in parenting education, or after the work in the home visiting systems coordination on child abuse prevention and intervention, is really showing how that partnership can really work. And we're really doubling down on that for the next 10 years. We have lots of other things we're doing, but that's the work really focused on early childhood. So I just wanted to share that so that you all can know what we are doing. We too are always recruiting. You think it's hard to recruit to where you guys, for you, Alyssa, try recruiting to Roseburg. That's really hard. So if anybody who wants to move to Roseburg and work on early childhood on any of those issues that I just talked about, we're looking. So that's the update from us.
Awesome. Very exciting. And Ford Family Foundation has been such a foundational piece of the philanthropic community in Oregon forever, as long as I've known it. But you continue to be leaders in a number of ways. So,
well, we work with many of the people who are on this screen all the time, including Peg, including Sue, including Alyssa, including Peter, including David. I mean, it's all about relationships and partnerships to make all of this work, and where we each bring our particular expertise or resources. So that's what it's all about.
Yeah, it sure is. Thank you. And I would be remiss if I didn't go back and thank Angie for representing us and sending testimony to the Legislative Committee on the Tribal Hub Bill. It certainly helps having you as a member of a tribal community representing the council. So thank you, Angie, for taking time to do that. Appreciated that. Okay, lots going on all over the state in our own worlds, and obviously way beyond what we've had time to talk about today. I'll be talking with kind of the council planning committee. I call us, it's David, Remy, Harriet, and Carrie from Build, about thoughts on how we follow up from some of what we heard this morning. from OHA, whether it's, workforce related or community engagement and these new community investment council idea. And there's a lot of focus on that. So what the council's role might be in trying to pull some of those together so they aren't just multiplying all the time, but I think Cully or somebody suggested, let's take advantage of what's already out there and see if we can support them and build on them. So more to talk about. Okay, council, so now what our official role in the world is, which is rulemaking. And I'll turn it over to Remy to introduce this, but just so you know, we're not adopting any rules today. This is sort of the prelude so that we know what's coming. And I appreciate staff being really sensitive to the idea that they're going to let us know what's coming. So we're not considered a rubber stamp for what's presented to us when we see it next month. So Remy, we're all yours.
Thank you. Thank you, Chair Miller, members of the council. Remy Watts, Early Learning Council Administrator, but today I am here as the division's rule coordinator. We have, like Chair Miller said, we have a few rules that we wanted to notify you of, and we're also going to give a few briefings. So the first part of this presentation is going to be briefings of rules that we're going to see in the future, not necessarily next month. And then we're going to end the presentation with the rulemaking that we're going to be presenting to you for vote next month. So I have some of my valued colleagues here. We have John Reeves, as mentioned earlier, for the suspension and expulsion reduction. We also have Alicia Gardner. She is the acting OCC director right now, and she'll be briefing us about a couple of other projects that we have going on. And then we also have Dana Blakeney-Hipsch, who has been working with me on the Baby Promise rule set. So we will start with John with a briefing of the suspension and expulsion rules. Thank you, John.
Awesome. Welcome, John. Good to see you again.
Thank you, Chair Miller and members of the council. It's great to be here for a brief update. I'm John Reeves. I'm the Community Systems Team Manager at the Early Learning Division, and I wanted to give you a bit of an update since the last time that we talked about the suspension and expulsion prevention program and the work that we're doing to develop an infant and early childhood mental health consultation model. So those two things are always a mouthful to say. So if I stumble over them, I say them multiple times, so you'll hopefully be amused. So on December 31st, Portland State University, who's been our partner, working with us on developing some recommendations for what our infant and early childhood mental health consultation model will look like. Their early childhood and family research department finished their community and partner engagement process, and they provided us with provided the Early Learning Division with a final report. It's called Centering Racial Equity, Design Considerations for Oregon's Statewide Infant and Early Childhood Mental Health Consultation Program. And we will provide that report today to the Early Learning Council. It is also posted on our website, and its official final version was provided for public consumption February 1st. And so that report culminated in recommendations and interviews that were conducted with early care and education providers and early childhood mental health consultants of color and leaders throughout Oregon, of which 65% of all interviews were with people of color. There was a significant contingent of rural area members that were interviewed. 76 individuals participated in 47 one-on-one interviews and 5 focus groups with the recommendations that are in that report, and which will be the foundation for the infant and early childhood mental health consultation model that we're building. The report centers race, culture, and language at its heart because we're working to change the trajectory of what we know to be true, which is that children of color and children with identified special needs are suspended and expelled at much higher rates than children that are white. That does not mean that children that are white are not also being suspended and expelled, and that's the foundation for this program that we're developing, and the system that needs to be in place is really to support our early education programs throughout Oregon to be able to care for the children that they have in their care. I just wanted to also give a quick update on, on February 9th, Alyssa Chatterjee and I presented to the Joint Ways and Means Subcommittee on Education and gave a progress report on the development of the model. And I'm pleased to say that they approved giving us access to the funds to build the statewide program. And that recording and the hour and 10 minutes worth of information is available to you on the OLIS website, and we can always give you a link to that. Also, please don't watch it with me. I can't stand to hear myself talk.
I just want to say that I have watched that, and Council, it's an excellent presentation on that program and the development of it. So I actually would encourage you when you're out for a walk or doing whatever to listen to that presentation. It was really very compelling.
Thank you, Chair Miller. And we'll definitely make sure you have the direct link to that. It's been an exciting month, though. So this is great timing for what is coming next. And so I wanted to give a little highlight that in late March, we will actually have an infant and early childhood mental health specialist hired at the Early Learning Division to lead the development of this system work. Super excited to have someone on my team that's directly focused on this all the time. And there will be a couple other positions that are hired at the division that'll support and walk alongside that specialist to develop the next steps of where the real meat of the work will occur. And so just in thinking about what is most important to you right now at the moment, which is sort of where we headed with the rulemaking process, the next steps will be we'll be recruiting for our rulemaking advisory committee in March, and then we're seeking to hold the RAC in late April or primarily in May. We'll be wanting to make sure that we're recruiting parents and early childhood educators and people of color and community-based organizations as participants. We're working with the Children's Institute and Black Child Development PDX to develop some of those committee recruitment priorities. If there's Early Learning Council members that would like to discuss the RAC framework and membership, you can definitely reach out to Remy or myself. And we're seeking to bring the draft rules to the Early Learning Council in June for promulgation. And so that is my brief update, and would be more than willing to entertain any questions.
John, did you send us the report that you mentioned? Is that report available?
That report is available, and I believe that Remy is going to add it to the chat box. Is that true, Remy?
It is true, and I already added it, but I will re-add it so it's at the bottom again. I'll also send out all of these links. I've got a list of links that I will be sharing in our follow-up email. So
thanks, Remy.
Yeah, thanks very much. Any questions of John? Obviously, this is a very important program model to figure out, and the RAC is going to be a very important advisory group for us. So if you do have suggestions of nominees for the RAC, please get those to Alyssa or John ASAP, so that we really get all the variety of input, the breadth of input that we need to make good rules. So thank you, John.
Thank you,
so are we going to then move to Remy? What are we doing? Alicia?
Yeah, we're moving to Alicia Gardner now. So Alicia, take it away.
Welcome, Alicia.
Well, thank you. Good afternoon. Thanks, Chair Miller and members of the council. I'm Alicia Gardner. I am the acting OCC director. And I'm here to update you on a couple of things. So the first update I have for you is around school age rules. So we're in the process of creating an entirely new rule set for standalone school age centers. We're currently engaged in a work group with external partners, and they've provided us a lot of feedback on redundant requirements when programs are located in public schools, requirements that are not applicable to this age group, and significantly, we've revised these rules to address qualifications as they relate to school age centers in particular. So really trying to address that center rules do not always fit with the school age care model. We're intending to move on to the engagement process and RAC within the next few months. And our current timeline is on track to bring these rules before the council in June. And we hope to bring an update to you in April on the progress of the rule set and the engagement process. Any questions on school age center rules? Okay, I will move on to the next thing then, which is the fire safety RAC. So as you all know, in January, ELC passed temp rules regarding fire safety in coordination with DCBS, who also passed rules to provide a low-cost alternative to sprinkler requirements in the building code. We are taking those temp rules to engagement and posting an application for the RAC this week, and engagement is next week. So we're hoping to bring those before the council in May to pass permanent rules. And that is all I have for that. Remy, or any questions?
Yeah, no, I mean, I don't have any. Are there questions that, now the fire one, this is the sprinkler one, right?
That's correct. Yeah. So the temp rules were related to family childcare and putting in some stronger safety requirements, particularly as they relate to emergency drills. So we're excited to get the feedback from providers on how that's going and suggested changes.
Okay, and I read your document, but I'm not remembering. The RAC is being appointed, has been appointed. You're looking for nominees.
We are posting the application either today or tomorrow on our website and our Facebook page. So we're beginning the recruitment process for that starting this week. It's going to be open, I think, for 2 weeks. And from there, I think we're hoping to get a RAC going in April.
Okay. Okay, great. Thanks, Alicia. I think, you know, from the information that was in our packet, council members, and you can see the RAC that staff put together around the baby promise rules. And I was very impressed with the diversity of that RAC, geographic, you know, providers, parents, professionals, et cetera. So I just really want to compliment staff on having the breadth of experience on these RACs. And I know the one on this fire safety is going to be equally important too, because there are so many different perspectives on that, which we've already heard some of. So that process is just really important for the integrity of what we do as a council. Any questions of Alicia? No, thank you, Alicia, and we appreciate the work you're doing.
So I wanted to note for you all, because you've heard from Alicia a lot, but Alicia is joining us as the acting Office of Child Care Director. She was formerly joining you all as the interim Field Operations Director. So I know you all know how long we've been waiting to fill this position. So just wanted to make sure you knew that Alicia's in that role now, and we're just really excited to have leadership back, and Alicia's already got so many great ideas, but just wanted to make sure you knew that she's wearing a different hat this time, and we're so excited for the work ahead. So just thank you, Alicia, for accepting the role.
Oh, huge thank you. I mean, talk about a critical one for kids, families, Alyssa, and the council. And you always do a great job presenting to the council, Alicia. So thanks for being a part of our meetings as well.
Well, thank you both. And it's an honor to be here, and it's an honor to be in this position. So I hope I can serve the position well.
Oh, I'm sure we'll be seeing lots more of you. So thanks. Okay, Remy.
We are moving on to the rule sets that we are presenting for vote in the March meeting. This is a semi-lengthy list, so pay attention. And also, I might add, all of this information is available in the memo to the Early Learning Council that's available in the meeting packet today. It's at the bottom. It's the notification of upcoming rulemaking. So I'm actually going to bring Alicia back, and then we'll move on to Dana with Baby Promise, and then I'll close it out. And then Sue, you can close out the meeting.
You've got it. And we have 11 minutes to do all of that. So sounds good.
Okay, I'll jump in and I'll be brief. So the first rule making that we are going to bring to you next time is regarding a couple things for CCDF and our requirements around that. The first one is around allergic reactions. So we received feedback from the Federal Office of Child Care that our allergic reaction rules are not strong enough. So we are revising our rules to strengthen providers' emergency response in the event a child in their care has an allergic reaction. Will involve requiring a written plan, notifying families immediately of any allergic reaction, and requiring all staff are aware of the plan, and also a caveat that staff need to try to keep this information amongst themselves and not in a place where other families can get a hold of that. So in order to respect the child and the family who is dealing with a medical issue. The second requirement around CCDF is around this child development training requirement. So ELD has to update its policies around the child development training to comply with federal CCDF requirements. We're currently out of compliance and we must align by spring 2022. So we've been working with a contractor to develop this training. It's anticipated to be available by this summer in July. And we are going to pass rules, hopefully that it will require all license types to complete within 90 days of hire, and then all current providers to complete by September. So there will be a big push internally to get everybody to take this training once it's developed. And we'll be bringing that rule, it's a one-line rule, to you next time. In addition, we have CBR rules that we will be bringing before you all next time. And the rulemaking is in relation to the current legislation that is in session right now, Senate Bill 1547. So our rulemaking and adoption is contingent on that legislation passing. The rulemaking will allow recorded programs and license exempt ERDC providers to be required in the CBR. The rulemaking gives ELD the authority to include both recorded programs and license exempt subsidy recipients into the pool of what we call subject individuals. So those are the three things that I have. Are there any questions on allergies, training requirements, or CBR updates?
How substantial are the additional training requirements? Is this going to be something that's going to make heads explode on the local level?
So this is where our intent is to keep this a free training. I think it's a 1 or 2 hour training. I think it's a 1 hour training, and free will be on the website, on our PSU website, similarly to our other trainings. And you know, I mean, it's going to be a lift this summer, but you know, it's lovely in that it's child development, and that we haven't had any requirement like that before in our system. So in that light, it's quite positive and exciting. But yeah, I mean, there will be a little bit of lift there this summer to get everybody in compliance with it. But I'm hopeful that we can see it as something that also will count towards the licensing requirement for everybody in their renewal, and that it will be perceived in a positive way.
Right. I'm glad it's about child development. That's great. Thank you for the info.
Yeah. So Alicia, just clarification on the CBR. Does the legislation have to pass in order for us to be allowed to adopt the rule?
I believe so. I think that if the legislation does not pass, we would not bring that for rulemaking next time.
If it's okay, I just wanted to add a tiny bit of context I thought might be helpful for folks. So this is the piece where currently the Early Learning Division conducts all background checks for licensed providers, but currently ODHS is conducting the background checks for license exempt providers who are participating in our subsidy system. There was a Secretary of State audit to bring those together, but also with the move of childcare subsidies to DELC, that makes that doubly important. So this also just gives us both makes this start to happen and also gives us a pathway to do that in a timeline that we think will be least disruptive for providers, as well as, recognizes that, we want to be able to spread this out over time. So that's part of the why we want to get that moving fairly quickly.
And I don't remember from Troy's presentation, is this one that we're expecting to pass?
Yes, it's part of House Bill 4005. So that'll be up in full Ways and Means tonight. Yeah. Mm-hmm.
Okay. Oh, good. Okay. Phew. Okay. Any other questions of Alicia? No. Okay. Then what else is on the to-do list?
We have Dana Blakeney-Hipsch next with an update on the baby promise process and notification for next month's rulemaking.
All right, welcome Dana. Thanks for being here.
Good afternoon, Chair Miller and members of the council. My name is Dana Blakeney-Hipsch, and I am the Infant Toddler Program Specialist that works at the division and oversees the administration of Baby Promise. I just wanted to thank you for this opportunity to join you all today and update you on our work. With the Rulemaking Advisory Committee, we've had 2 meetings to review and further develop the language for Baby Promise. And as Chair Miller noted, we had a tremendous response to our request for application for this RAC. It was very, very exciting. So to all the points that Chair Miller mentioned, when it comes to our racial, cultural, linguistic, geographic diversity, we were able to check all of the boxes, along with getting unique perspectives from both family and center-based childcare programs, Hub and CCR&R staff, tribal representative advocates, so on and so forth. So it was very great. This group reflected on the rules and suggested edits to help us navigate a number of issues. One being kind of the tension in our professional development requirements, given considerations about training and educational inequities in our system, along with review of the program requirements, and then just preferred terminology or additional edits to bring clarity to these rules. For next step, the rules will be available for public comment March 1st through 21st. And on March 16th at 5:30 p.m., we'll have a public hearing. And then after that, we'll be back at the Early Learning Council meeting in March for your review and consideration. So thank you for your time.
Oh, thank you, Dana. And can I just ask, because I was interested in the RAC feedback that's in the report you gave council. So I'm hoping in the report that comes to council that you'll spell out how you handled the fiscal and equity concerns in response to the feedback that you got. So
absolutely, we'll be able to dive into that more next month. It was a very exciting and I think really great learning opportunity, and will inspire future work beyond Baby Promise in the future.
Awesome. Thank you, Dana, very much. Okay, Remy.
Thank you, Chair Miller. Just very quickly, last one, and this is going to sound familiar to everyone. We passed some temporary rules back in October relating to the payment of commissioning council members. We hit a speed bump with our Tribal Advisory Committee where we weren't allowed to reimburse our committee because we were missing an administrative rule. So that's where y'all came into play. You passed these temporary rules for us, and now we're just coming back with the permanent rulemaking so we can continue to reimburse councils and committees that aren't created underneath the governor's jurisdiction. So pretty quick, pretty easy. Any questions on that? Excellent.
Like a good move.
Thank you.
Thank you, Remy, doing a great job as our rule administrator, council administrator, etc. I want to thank again Remy, Harriet, Carrie, and David for all of the work that goes into planning these council meetings. We have amazing staff support, and I just want the whole council to be aware of that. So thank you all for your time and your energy and what you do, not just in our meetings, but in the rest of your lives and your work. Have a great rest of your afternoon and be safe. Bye-bye.
Thank you.